Is roll call, please.
Teresa Taylor. David Miller. Controller Malia Cohen. Frank Rufino for Fiona Ma.
Present.
Lisa Middleton.
Present.
Ariana Ortega. Jose Luis Pacheco. Kevin Palke. Ramon Rubacaba. Yvonne Walker. Melissa Willett. Dr. Gail Willis.
Thank you. I want to be careful and make sure it's off, not on. I want to welcome everybody to day 2 of our Board of Administration Executive Team Offsite meeting. And just like yesterday, the meeting's being streamed online for anyone who wants to follow along. We also have stakeholders and members of the public here in person, and we're glad you can be here. Welcome. Enjoy Monterey while you're here. There will be public comment periods throughout the day for anyone who wants to share their thoughts. So if you are viewing online, you want to make public comment, please call 1-800-259-4105. Again, that's 1-800-259-4105. If you are one of our stakeholder relations team, will be standing by to assist on the phone. But if you are here and want to make public comment, we ask that you fill out the card and give it to one of our stakeholder relations folks. And for now, I'm going to turn it over to Marcy Frost, our CEO, for her opening comments.
Good morning, everyone. So hopefully I won't take away Dawn's talking points to start the day, but we have several healthcare presentations planned, starting with an action item to approve the 2024 healthcare premiums for both the HMO and PPO plans. That will be followed by a review of the annuitant contributions and the association plan premiums. Doctors Logan and Albers will then present a comprehensive look at the health of our member population and talk about our work to improve health outcomes for several disease states while enhancing behavioral health services. We'll also be getting an update on specific initiatives in the strategic plan associated with member experience and organizational excellence that will be done by Sabrina Hutchins and her team. And then finally, our financial office will introduce the new transparency report and talk about our work to align practices with CEM benchmarking standards. I know the new transparency benchmark just came out. CalPERS scored very well there, and I know Sabrina will give you an update on that as well. And then just a quick update for you all. Normally we would announce our investment returns on either the Friday before the offsite or on Monday. We will be announcing the investment returns tomorrow morning as a part of my update at that time. That does conclude my remarks to start the day, Teresa.
All right, thank you, Ms. Frost. So we're going to start the day with an action item to approve the 2024 health premiums for health maintenance and preferred provider organizations. Here to present is Mr. Rob Jarombic, Chief of our Health Plan Research and Administration. Rob, welcome and thank you. Get started.
Hi, good morning, everyone. Good morning, President Taylor and members of the board. Rob Jarombic, CalPERS team member. The 2024 HMO and PPO plan premiums are action items for your approval. The final premiums have been provided to you and are now available on our website. Today, I'll walk through the final weighted average premiums for next year. We'll discuss the PPOs and transitioning to one risk pool for the basic portfolio, which is a continuation of the conversation we had in June. We'll ask for a decision on risk pooling, followed by approval of the 2024 HMO and PPO plan premiums. And lastly, I'll share the next steps. Here are the proposed 2024 basic plan premiums and percent changes. As a reminder, the numbers here and throughout the presentation are the state single party premiums. The regional premiums for public agencies and schools can be found in the attachments posted on the website. Based on the discussion we had in the Pension and Health Benefits Committee last month, there was a general consensus to transition to one risk pool for all basic plans starting in 2024. Therefore, this table shows two sets of 2024 premiums. The first set shows the premium and percent change with a 2-year phase-in. Next to it, on the right, are the premiums with a 3-year phase-in, which include making modest benefit design changes to the PPOs. This one is our recommendation, shown in green. There have been 2 changes to the premium since you saw them in June that I'd like to highlight. The Anthem Select premium was reduced by 6.8%. That plan now has an overall 2.4% increase. This improvement was made possible as a result of a recent cost reconciliation with an in-network provider. The Anthem traditional premium went down 0.5%. There were no other changes to the premium since June.
Can you repeat the change and speak more into the mic?
And a little bit slower, Rob, sorry. It's lots of numbers.
Lots of numbers,
Yeah.
I agree. So there have been 2 changes since we saw the premiums in June. And so the first is the Anthem Select premium. So Anthem Select went down by 6.8%. So the overall premium increase for that plan is 2.4%. So this improvement was made possible as a result of a recent cost reconciliation with an in-network provider. The Anthem traditional premium went down by 0.5%. There were no other changes to any of the premiums since June. So the overall 2024 basic weighted average premium increase is now 10.95%. So there are no changes to the Medicare plan premium since June. The 2024 Medicare weighted average change remains 9.55%. This slide summarizes the premium changes for the basic and Medicare plans under each of the 2 scenarios. Our recommendation, again shown in the far right column in green, has an overall weighted average premium increase of 10.77%. Let's now talk about the PPO options and recommendations for risk pooling. As we've discussed a number of times now, without transitioning to one risk pool, the PERS Gold and PERS Platinum basic premiums will have a 19.3% increase. The PPOs are experiencing continued high medical cost increases and high pharmacy costs resulting from more utilization. They also have a premium surcharge that was approved in 2022 to rebuild the reserves in the healthcare fund. Additional surcharges are needed for the PPOs next year. Therefore, included in the 2024 premium is an increase in the surcharge from 3% to 5% for PERS Gold and 2% to 4% for PERS Platinum. The challenge we're facing with the PPOs is sustainability. The 19.3% increase is unsustainable as we will lose a large amount of healthy members. We project a substantial migration of healthy members out of the PPOs to the HMOs later this year during open enrollment. With this migration, the gap in the risk scores between the HMOs and the PPOs would continue to widen, with the PPO risk increasing significantly. This puts more pressure on the costs and adversely impacts the healthcare fund and our ability to replenish the reserves. The PPOs have started to become unsustainable, making now the time to take action. This is an important visual that we presented in June. It shows that with the PPO premium increase of almost 20%, we anticipate that about 11% of members would leave during open enrollment, and the majority of those members would be healthy members. Under the transition to one risk pool, the outward migration lowers significantly to about 3% in both scenarios. Taking a look at the risk mix of the HMOs and PPOs, this chart shows that the difference between them is increasing more rapidly than before. Without changes, most healthy members will leave the PPO for the HMO, making the PPO premiums unaffordable for everyone. Now let's look at the premium increases by scenario. A 2-year phase-in to one risk pool would lower the PPO premiums by 7.7% to 11.6%. It would add 1.9% to the HMO premiums for an overall HMO increase of 11.1%. A 3-year phase-in, which would include modest PPO benefit design changes, would mean a 12.2% PPO increase and a 10.5% HMO increase. Either of these options is viable for lowering the PPO premium and would begin to stabilize the basic PPO. The 3-year option has the advantage of lowering the HMO increase in an already difficult year by 1.2% rather than roughly 2%. Transitioning to one risk pool with a 2-year phase-in would not require changes to the benefit design. However, to get the PPOs to the premium level needed to avoid the outward migration of healthy lives, the 3-year phase-in requires making modest benefit design changes. To do this, we propose to increase the cost sharing for out-of-network care from $500 to $2,000 for PERS Platinum, and from $1,000 to $2,500 for PERS Gold. Making these benefit design changes would reduce both the Platinum and Gold's premiums by 1.2%. After our discussion in June, we wanted to better understand the impacts to the 5,300 PPO members who exceeded their out-of-network deductibles in 2022. Our analysis shed light in a couple key areas. First, this isn't a rural access issue. Of the 5,300 members, the average out-of-network usage for members in rural areas is about 15% lower than the usage we saw for members in urban areas. Therefore, members in urban areas are seeking out-of-network services at a higher rate than their rural counterparts. Next, the most costly conditions that members seek care for, both in and out of network, are virtually identical. Said another way, the out-of-network claims aren't for any type of care that's not readily available and frequently being used by others in network. Those top 3 areas are cancer, hypertension, and depression. Here's a summary of the premium impacts again. Under either the 2-year or 3-year phase-in, the PPO premium is roughly 7% lower. One additional advantage of the 3-year phase-in is that HMO members will experience a smaller premium increase. For example, a single Kaiser member would pay about $70 less a year in premiums, and a family in Kaiser would pay about $200 less a year. For the stability of the PPO program and the healthcare fund, either option would adjust the PPO premium to help ensure it's a viable product in our portfolio long-term. In particular, PERS Gold would remain one of the lowest cost plan options available throughout the state. We recommend the board approve the transition to one risk pool over a 3-year phase-in while making modest PPO benefit design changes. This would stabilize the PPOs while minimizing the impact to the 2024 HMO premiums. For next steps, we'll ask the board to approve either a 2-year or 3-year phase-in to one risk pool. Then we'll ask the board to approve the respective final premiums for 2024. Once approved, we'll begin our communication efforts. We have significant communications planned in advance of open enrollment and will encourage all members, both basic and Medicare, to shop using our new tagline, "Shop Health Plans and Find One That's Best for You." Each member's CalPERS account has a number of tools they can use to determine if their doctor is available through a more affordable plan. Members can see all the health plans available in their area, view premiums and member satisfaction ratings, compare benefits, and even make changes to their health enrollment online. For this year's open enrollment, members will be able to search Medicare doctors and Medicare plans and medical groups in basic plans. This is in addition to the primary care physicians, specialists, and behavioral health providers that are already listed in my CalPERS. In late August, we'll send letters to members in plans with experiencing a 9% or higher premium increase. These letters will include guidance on shopping for health plans. And new this year, we're including information on how much members could save by shopping and switching plans to a more affordable plan in their area. This is in addition to the list of resources that are available for members to use to make an informed decision. The rest of the slides that follow are the basic premiums under the 3-year phase-in and the Medicare plan premiums and the respective cost drivers. This concludes my presentation, and I'm happy to take any questions.
Thank you, Rob. I do have some questions. I think Mr. Rubalcaba, were you first, and then Mr. Pacheco.
Thank you, President Taylor. Thank you, Mr. Jarzobek, for a great presentation. I know this, in June, we had quite a discussion on the need for the stabilizing the PPO and how to do it. I had the month since, I've had the opportunity, thanks to Trustee Ms. Millett, to meet with some members from County of Monterey, and I understand how important accessible, viable PPO is, and I want to make sure that this board takes whatever we can, every action we can to make sure we have viable PPOs. It's unfortunate that the way to do that is to go into one risk pool which will have some adverse impact on the HMO members. However, our goal is to have a viable insurance program, and insurance, that's the way it works, where we sort of spread the risk, and the broader we can spread the risk, I think it would be the best. So I would be in favor of the staff recommendation, which is to move from one risk pool to from two risk pools to one risk pool over a 3-year phase, with the modest PPO plan design changes.
Thank you, Mr. Rubalcaba. Mr. Pacheco?
Yes, thank you, Mr. Chapagat, for your comments and so forth. So I'd like to, as our chair has mentioned, and our committee chair, Mr. Ramakoma, I'm very disappointed that Kaiser Foundation Health Plan, came with these high premium rates. We had hoped that Kaiser would have collaborated with us more constructively to arrive at health rate premiums that would. Sorry. We would have been happier if they had come with us with better rates. Over the decades, we have our CalPERS members, which are about 550,000 members, approximately of the 1.5 million active members, have helped grow the market share of Kaiser in California for a long time. And many of our members, a big chunk of our members, have helped with their reserves over these years. They've grown their market reserves. Just very disappointed in what they had. They still came up with these high rates for us. Regardless, I, as the committee vice chair, I move to approve the 2024 health maintenance premiums, and approve the 2024 preferred provider organization premiums, as well as the transition to the one risk pool over a 3-year phase, while adopting the modest PPO benefit design changes.
Okay, so I have to take public comment before we vote on this. So we have a motion and a second to approve the rates. And before that, I have a public comment in the room. That's Mr. Jelensik. Please come up to the microphone. You have 3 minutes.
J.J. Jelensik, speaking for myself. Last year, you told Kaiser that they weren't spending enough, so you hit them with a $45 per member per month surcharge. This year, they said, okay, we'll spend more. You said, not good enough, so you're gonna hit them with the $68 per member per month surcharge. This board has deliberately adopted a policy that says to high-cost, inefficient plans, we will subsidize your business and help you grow it by subsidizing your members. And you're telling low-cost, high-control plans, we're going to punish your business by hitting your subscribers with a surcharge and using that to subsidize the high-cost plans. Now it's even worse. You're having the HMOs subsidize the PPOs. You criticize Kaiser for coming in with a 8.16% increase, and you talked about how terrible that was. The PPO is coming in with an increase that's over 150 times that much, and your reaction is, oh, we better subsidize them. Encouraging the growth of expensive health plans is not going to lower cost. If you advocate and believe that these policies actually will lower costs, then either you're fools, your economic well-being depends on not understanding, or you're on the take. I urge you to reject these rates. And one other thing, I want a Lamborghini for the price of a Jetta. They're both cars. In fact, they're both Volkswagen products. You're significant shareholders. You should be able to make that happen for me. Thank you.
Okay, thank you. We have public comment on the phone for this item as well. Anybody? Susan, is that you?
Yes, Madam President, we have Larry Woodson from CSR regarding health rates.
All right, thank you.
Go ahead, Larry.
Yes, can you hear me okay, Madam Chair?
Yes, we can.
Okay, good morning. Larry Woodson, California State Retirees. Madam Chair, members of the board, thank you for the opportunity to comment. I'm unable to be there in person this year, but I appreciate that this meeting is webcast and we can comment by phone. Glad to see some downward movement in two of the plans, but it's very disappointing that Kaiser and United Healthcare in particular are retaining their same high increases. It's just not acceptable. I would again point to United Health, whose parent company, UHG, made $16 billion in profits last year, and their latest quarterly profits were just reported as extremely high. As I stated in my comments in June, they ought to be reducing premiums rather than increasing. I want to shift my comments slightly to address something that will affect rates, Medicare rates in the future, and that is the ACO REACH, which is of concern to, as you know, CSR and many health advocacy organizations and government bodies throughout the country. I did send all board members and CEO Frost and Health Benefits Director Moles an email Sunday afternoon with a written report on my research and analysis of the 2023 REACH ACOs that CMS approved. There are 132 nationwide, 27 in California. That means that thousands of CalPERS retirees have been moved into REACH without their prior knowledge or consent. Medicare plans for these ACO beneficiaries are now managed by for-profit companies, many of which are PE companies and private equity, who, as you know, have the sole mission of maximizing their profits. I'm sure that most of you haven't had time to read my report due to all the issues before you, but I hope that you find time to read it soon. And I focused my research on the 27 California ACOs, and what I found is the shocking lack of compliance with CMS requirements, ACO websites full of outdated information and lacking transparency for beneficiaries, some not even referring to the ACO program. And most seem designed to promote their company to providers in spite of Liz, In spite of Liz Fowler's assurances to you that the ACO applicants were carefully screened, that does not appear to be the case. In conclusion, if you read the report, CSR hopes that you will, at a minimum, put a topic for discussion on your next PHBC agenda to consider asking President Biden to terminate the program. It appears that Assembly Joint Resolution 4, which easily passed the State Assembly and should easily pass the State Senate soon, asking Biden to terminate the REACH program, will go forward. Hopefully this board will choose to do the same. After voting on premiums,
Mr. Woodson, you are out of time. Mr. Woodson, you are out of time.
Okay.
Thank you, though.
I hope you can agendize this.
Thank you. Bye-bye.
Thank you.
Okay, so I have two more in the room. First is Maureen Thompson to come up, and then we have from CSR, and then we have Elnora Fretwell from CSR as well. So, Maureen, and you have 3 minutes.
This is better for me. Thank you very much, board members. I am the new chapter president of Chapter 36. We cover Santa Cruz, San Benito, and Monterey counties. In Monterey County, we have 4 hospitals, a small one in King City, Chomp Community Hospital in the Monterey Peninsula up the hill there from where we're at, and then we have 2 in Salinas. Where I live in Soledad, it's 30 miles one way to my doctors. I am very concerned about the PPOs because even though I have Anthem Blue Cross Platinum, and I have medical insurance from my dead husband and Medicare, it still costs a lot of money. I am concerned that forcing us, I've lived in this county since 1981. There's only been one HMO in Monterey County, and it didn't last long. We were all required, as I was a teacher, I was required to be part of it. So please pay attention to the PPOs because there are a lot of people who have no other access to health care. And confining us to doctors is very difficult. I've had a couple doctors retire. Thank you very much.
Elnora Fretwell, Executive Statewide President for CSR. Now, I'm not educated well on some of this subject, but I know the premiums are high. I don't know if, and I hear that, Jose said he don't like what's going on, he don't like it, but he's voting for it. I don't know if you say no to Kaiser now, where we end up at. I don't know if that can happen. If we say no, we don't want none of this, where do our members go? Who do they see? So that may be a bigger background to explore. But I'm asking you, since today you know this, when we come up again in a couple of years, maybe you start now looking for other hospitals and not doing them and saying what's what, because I think you might be in a bind right now. I'm not sure because I don't know, that you have to say yes to something that we don't like. So if you can start now saying, well, maybe forget you, Kaiser, United Care, we're not going to do anymore, and do something for other hospitals that's going to do best for your members, right now, and do that. So I ask you to look into that for our members, because this is high. I heard about the 1,000, 2,000 for the PPO people, and I know that's going to, it's going to hurt them. So like I said, I don't know if you're in a bind right now and you have to say yes, because if you say no, we have no doctors, nowhere to go. I'm not sure because I don't know the process, but I'm asking you, please, for next time that comes up, don't pick these hospitals. Try something. Start now trying something else better for the members. Thank you so much.
Thank you, Ms. Fretwell. I agree. I do know, Rob, if you want to kind of expand on it a little bit, when we're done here, I have a phone call I have to take. Just the work that went into this and why we've kind of settled where we're at. I'm not any more happy than anybody else on these rates. I just realized Yvonne's waiting to talk. So, yeah, so let me take Yvonne and the phone call.
Rob can go, and the phone call, I can wait.
Okay. Oh, and to Dawn. You want to go ahead?
Yeah, I'm happy to, I think the last comment was a good comment. This is a difficult year, as you know. There are a lot of things going on. The underlying challenge is medical inflation, which is pushing all rates higher. We have some rates that considering the high level of medical inflation look pretty good this year, and two rates in particular that are outliers and look very bad. And the challenge is that we have exposure, a lot of exposure to both of those sets of rates. So one is the Kaiser rate, of course. We have half of our HMO members in Kaiser, and the other one is our PPO. And part of the high rate in our PPO is the fact that we're having to work aggressively to replenish the reserves that we lost in 2021 because of the experience coming out of COVID. So that adds 4.5% to that rate. The Kaiser rate came down a lot. We worked very hard with Kaiser to bring that rate down. It's still high. We have deep concerns about the long-term medical trend in Kaiser, and will be working, have been working and will be working with Kaiser closely to try to affect changes in the opposite direction going forward. You're going to see the high Kaiser rates, not just in CalPERS, but in the rates across the state. So it's not a good year. It's certainly not been a good year for us. These are the best rates that we could come up with. There are not improvements out there that we see in our own analysis. Remember that we do our own build-up. And we do not disagree with these rates based on the medical trend that we're seeing in the pharmacy trend. We think that there's a lot of room for improvement on the medical trend. As we've talked about in the past, we're doing much better on pharmaceutical rate trend than we have historically. We're doing better than anybody in the market. We can say that with a high level of confidence. Medical trend continues to be a challenge. So that will be a challenge not just this year, but in the future. And so it's something that we're going to need to be innovative about in our approach. We have the PPO reprocurement coming up. We're looking at a lot of novel approaches to bring down costs in the PPO. We're excited to bring them to you and to talk with the stakeholders about their implications. But we're optimistic that we have some tools to address this going forward.
Thank you, Mr. Bowles. I know that our staff is working really hard on our healthcare rates. It's difficult. We had this discussion about the one risk pool and what we have to do, but also about Kaiser. And it's tough because most of our members are in Kaiser. So we do appreciate the work you guys do on that. Ms. Walker, before I take the phone call, go ahead.
Thank you, Madam President. So I want to say from the beginning, I appreciate all the work that has gone into this. I don't think we fully appreciate the commitment that Don, Rob, and the rest of the staff have to trying to lower rates. I will say that we have to think of, and I don't know how it's possible, but we have to think of a different way. If we're just negotiating rates, we will always be in this position. So we have to figure out what are the other factors that impact healthcare costs and how we can best weigh in to serve our constituency, other than just rates, just negotiating rates. And I would welcome that conversation, trying to figure it out. I do think that the Health Benefits Committee needs to meet more regularly because, I mean, it's hard to meet for this as we're, you know, coming on. You're always going to be in a sucky place, right? When I was president of Local 1000, we had shifted from just beating up on CalPERS when the rates came, and we're beating up on the healthcare companies, right? And we saw some movement from Kaiser. So we've got to figure this out with our stakeholder groups, right, on what we're doing, how we're doing it. I think it's unfair to hold our staff accountable to rates, because believe me, if they had the option of coming in with single-digit rates, they would be dancing in the room and slapping them on the table and be happy for everybody to have that, but they don't necessarily have that option. And my final thing I want to say is, I don't believe $1,500 is a modest benefit design change. I think it's a major benefit design change. I spoke last time. I do think I am opposed to the motion on the table. I do think that we should go for the 2-year phase-in with no benefit changes. This whole thing, whether it's 2 years, 3 years, it's a hard decision, right? And so, but I just think $1,500 is huge. And I don't know, I don't feel like and I appreciate the work that's gone in from the last meeting to this one to try to bring some answers, but I still don't feel comfortable knowing the reasons why, even if they've gone out, why. It could be that, you know, if it's cancer, their cancer doctor, like that might be the first doctor they went to, and that's the doctor they're counting on to keep them alive, right? And they're not really, it doesn't cross their mind to think about, oh, maybe I can go to somebody else and it'll be cheaper, you know? Personal story, when I was younger, my daughter had an accident, cracked her skull in 3 places, had to be life flighted to Children's Hospital in San Diego, right? So all of the costs that came up, right? The paramedics came, they had to transport her to the life flight. Life flight was not covered by insurance, so that was a cost. Checking into Children's Hospital, you had to go through the sharp emergency room before walking down a hallway to Children's. You were charged for both. The neurologist that came was not on Children's staff, and Children's Hospital is great because they're free, but the neurologist was from La Jolla. And when they came to tell me what they needed for my daughter, I didn't ask, are you in network? Am I going to have to pay other costs? It took me 7 years to pay off that medical bill. So it's never, and I was employed. I was in the Marine Corps, and they should have covered most of it, and they didn't. So, you know, it might seem small, and it might seem like we're just impacting, you know, a few people, but the impact on a few people is a major impact on them. It is not a small impact, and the impact that it's going to have on their lives is not a small impact. And for that reason, I'm opposed to the motion, and I'm more in favor of the 2-year phase-in with no benefit changes. Thank you.
Thank you, Ms. Walker. So I have 3 people on the phone lines, if we want to go ahead for the first one.
Yes, Madam President, we have Elizabeth Tyler calling, representing herself, calling regarding health rates.
Thank you.
Go ahead, Elizabeth.
Hi, thank you. Hi, my name is Elizabeth Tyler, and I work for Monterey County Children's Behavioral Health. And, you know, I guess the only comment I want to say, because I don't know how things work at the level at which y'all are trying to operate, and I believe in the motivation of trying to get the best possible rates for your members. I believe in that. And at the same time, it's almost inconceivable to me that an organization as broad and as powerful as CalPERS is accepting these kinds of increases. I mean, it mystifies me that there couldn't have been a stronger negotiation to get to a better offer for our membership. That's really all I wanted to say. This is going to directly impact how I live my life, with my family. It's going to directly impact, when my husband, who's a heart patient, goes to the doctor. I'm going to have to think that over because we've got a great cardiologist and a cardiothoracic surgeon, but maybe I need to change my health insurance because these rates are just going to be prohibitive for me and my family. So just wanted to put that out there for y'all to think about. Again, I'm proud to be a union member. I am really have faith in your intentionality, and the execution, I feel, in this instance could have been better. And I agree with the previous speaker who said maybe start working at it like right now for whatever's going to happen 2 or 3 years from now. And maybe that would have a better result. And thanks for your time. And just so you know, anytime anyone asks me, hey, do you have something you want to say? It turns out I'm always going to say, yeah, I got something to say. Thanks for your time today.
All right, so we have a motion on the table for accepting the healthcare rates with the one risk pool. Oh, go ahead. Let's go.
Good morning, everyone. Mr. Moulds, you said something that kind of struck a chord with me, and I was curious if you could explain to me what drives medical inflation.
So medical, wow, yikes. Many things that drive medical inflation. General inflation is one of them, because when you think about operating medical facilities, for example, energy costs have an impact on medical costs. The cost of things like materials like steel or plastic will have an effect on medical costs. So it tracks to a certain degree with general inflation, which last year ran at close to 8%. It's coming down now. The other major consideration is labor cost, and as general inflation comes up, increases, typically the cost of labor will increase also. There are a bunch of dynamics within medical costs that are unique to medical costs. So issues like consolidation impact medical costs. So we've seen over the last decade and a half in California that there's been significant consolidation. We have about a 30% spread in the difference in costs of medical care in Southern California versus Northern California. A lot of that has to do with the fact that there are many more consolidated markets in Northern California as opposed to Southern California, where they're much more competitive markets. So it's really a lot of things. It's tracked nationally. It does not track as well in California. It's sort of after the fact tracked pretty closely in California. But we're seeing nationally the most recent figures I've seen in anticipation of 2024 are about 7%. California is going to be higher this year for a number of reasons, including the Kaiser challenge. So.
Okay, another question. I think maybe this is for you, Rob, to the staff. What are the alternatives? We reject this motion. We reject the staff recommendation. Where does that lead us?
So if we were not to approve the rates or not to approve one of the plan's rates, then that plan would no longer be available to CalPERS members. And so then we would have to make contingency plans on where those members would go. And so that was going to be, they would need to go someplace else to get their care.
And have you presented this body alternative contingency plans for us to consider?
We have not.
And for what reason?
So contingency plans would include, I mean, basically what you would be doing is you would be shrinking the options for CalPERS members. Conceivably, they could go find alternative care, but in many instances, they would have to leave an existing relationship with a doctor or another provider, which is challenging to their health. So I think, in our view, it is healthy for us to look at long-term which plans we're contracting with, and to consider dropping plans that we think are inefficient plans. We dropped a plan in the 5-year procurement, for example, but to do it in an abrupt way is hugely disruptive to people's health care and has adverse health consequences.
Have you studied, I guess, you know, we have actuarials at the table, Scott, that talks about smoothing, right? Have you looked at or reviewed a plan or a strategy to shift us away from the more costly plans and into something that is more affordable for our members, that isn't abrupt, but in a thoughtful, measured manner?
Yeah, we have. So one of the things that we've done over the course of the last three or so years is increased a number of low-cost HMO options that we're aggressively leaning into. So the TRIO plan, which was approved 3 years ago, which is a narrower network, lower cost HMO option. Western Health Advantage, which is a low-cost option in Northern California. Saluti Moss, of course, in Southern California, and then United Healthcare's Harmony, which is available now in Southern California and 2 Northern California counties. We're looking to expand it into more Northern California counties going forward. So we've done a couple of things. One is lean into those, and we're pushing the health plans as aggressively as we can to get them in as many counties as quickly as possible for 2 reasons. One is to give people low-cost options, and the other is to put price pressure on the plans that are at higher price points. So when they have competition, economics says that it puts pressure on them to try to be more efficient to compete, because if they don't, they lose market share. So that's one of them. The other thing that we've done is we've added EPOs, which are HMO-like entities in the rural counties that previously had only the PPO available. So one of the downsides to the PPO product is the cost sharing for our members is significantly higher than in the HMOs. So the actuarial value of our HMOs is about 97, 98%. It's in the low 90s and the 80s for the PPO product. And that's because when you go to a doctor, you pay more. So the premium to premium isn't the only comparison. The other comparison is the out-of-pocket cost. So we now have an EPO or an HMO option in every county in California as of last year, which is, we think, another important way for our members to have choice, and in some places lower cost choices.
You said aggressively leaning into some of these alternative plans. What does that look like? I mean, are you studying it, or are you some of the rural counties? What does aggressively leaning in mean?
So
or
it
look
means
like?
the board has approved the board has approved them. Every year in our rate negotiations, we talk about, we ask them, or in some cases insist on them expanding into additional counties. So traditionally, HMOs, all the health plans have been very enthusiastic about going into Southern California, where costs are low and margins can potentially be higher, and we've leveraged entry into those markets with a commitment to expand in the north as well. Sorry about that. Yeah, I'm afraid if I pull it too close that I'm going to rip everything out of the, but I guess I should just lean into it. Yeah. So in our negotiations with them, we will ask them to move into areas that are harder areas. 2 good examples of this in the last few years, we're bringing the TRIO product into Monterey here, which is one of the low-cost HMO options, and we think critical for Monterey, where costs are extremely high, and into Santa Barbara, which is another area where competition is a challenge, and having a low-cost HMO is really critical. In the negotiations over the 5-year contract, we were able to secure commitments to go into many Northern California counties that previously had very limited lower-cost HMO options.
Thank you very much. And CalPERS is a big deal, and I would imagine in the marketplace, the decisions that we make and the decisions that we do not make will have an impact. What has been our most significant bargaining chip in trying to get these rates reduced? What was the strategy? And again, this may have already been presented to this body. My apologies, I just need.
No, it's a good conversation to be having. CalPERS is the second largest group purchaser in America, the largest one in California, so on the commercial market. And if you were to ask for sort of a single thing to point to as our advantage, it is our size. We are a very important partner for a lot of these health plans. Not being able to market products, to sell their product to our members is, sorry, did it again, there, it is a problem for them. So so we're judicious about the health plans that we contract with, and we push them to do things that are good for our members when we do contract with them.
So if this plan said no thank you, again, to the motion that was being presented today, what do you think the effects would be, the ramifications in terms of the greater marketplace?
So it would have
Would it force Kaiser to come back and negotiate and say, okay,
so
we made a mistake, we actually can lower? So
we have been negotiating with Kaiser for many months now, and their rates dropped from close to 16% as a raw rate before risk adjustment to a rate that was a little bit below 10%. So they came to the table. It was a tough conversation. We've had other tough conversations about the medical costs and the trajectory going forward. We are going to have another tough conversation with them next year. And between now and next year, it would have a devastating effect on Kaiser to not have CalPERS in their portfolio. We are, I believe, their largest client. It would be devastating, in my view, for our members, too. One of the unique aspects of Kaiser is that Kaiser is the only way of getting to see Kaiser providers. And so we have families in CalPERS who have pediatricians who are Kaiser pediatricians, and primary care providers who are Kaiser primary care providers. Every one of those nearly 500,000 CalPERS members would have to go out and find a new doctor and a new provider healthcare team in the open market. It would be challenging to do that in an environment where supply is tight, and it would be disruptive to those relationships. So it is genuinely a difficult spot for both parties. And that was part of the conversation that we had, of course, during the negotiation. But it is, if Kaiser were to become over time too expensive for CalPERS, my strong and we just couldn't afford Kaiser going forward, my strong recommendation would be to gradually make changes, not to do something in a single year by essentially throwing them out and asking our members to go find somebody new.
So based on kind of my rough analysis, I don't have a lot of staff around me helping inform my decisions here, but it looks like that's the trajectory that we're going in. And at some point, we may not be able to afford Kaiser.
I will say this, I am an optimist by nature, which some people read as naive, but I am optimistic that we can get there over time with Kaiser. Kaiser has a long track history of being an efficient provider, being a low-cost leader as well as a high-quality leader.
But Kaiser also has a reputation of being very difficult to work with. You think about the nurses, you think about the techs, they're constantly going on strike for better wages, more fair work schedules. So I don't know, I too consider myself to be optimistic, but I don't know if I'm that optimistic on the direction of Kaiser. There's been a leadership change since Bernard Tyson has passed away. And I think that has been a loss that has injured Kaiser's overall ethos and the space that they occupy. And I think what really concerns me is that, well, actually, the decisions that we make today, I would imagine, are going to have an impact on your negotiations next year, and future ones for that matter. So how do we begin to stand up for ourselves and say, you know what, we disagree with these fee increase, recognizing that they need us and we need them?
So, we have done a good amount of that in getting to where we get. I recognize that these are still extremely high rates, but we pushed back very hard on the initial rates and worked intensely with Kaiser, as I said, for many months to get where we are, which is not where we want to be, but much better than where we started off.
Well, what if we started off, they started off the conversation and negotiation artificially high with an effort to try to get us?
We build up our rates independently, so we do as part of the rates process, and this is new since 2019, but we completely independently build up the rates based on so we have access to all of the claims for all of our health plans, including Kaiser. And Emily Zong, who's sitting in the front row, who is our lead health actuary and is fabulous, works up with her team completely independently of Kaiser before we go into the negotiation where they think Kaiser should be based on a combination of past experience and future projections about medical trends, so the inflation factors that we talked about. Our build-up rate within CalPERS is extremely close. It's essentially identical to where Kaiser is now. As I said, we have deep concerns about the medical trend, but we do not feel like this is a rate that is excessive given what they are actually spending. We just think that they need to be spending less.
Final question. Has a survey been conducted of our plan members that are Kaiser?
We conduct a survey every year of all of our members, and then we break them out by plan as well.
And was the question asked, if rates increase, will you continue to stick with Kaiser?
We did not ask that question. We have partnered independently with an economist at Cal named Ben Handel, who looks at price sensitivity and the prices at which people will change. And in general, CalPERS members are, the term in health policy circles are extremely sticky, which means that they tend not to leave their existing plans. Kaiser members are much more sticky than even our other members, and the reason comes back to this issue that we talked about earlier, which is that when you leave, if you go from United Healthcare to Anthem, for example, you could conceivably keep exactly the same care team. So if you're in Sacramento at UC Davis, you can see the same group of doctors and nurses with a different health plan. So it's not a big change. If you leave Kaiser and go to United or Anthem, you have to give up those relationships. And that is a really daunting prospect for a lot of our members. And it is also, generally speaking, not good for your health. Continuity of care and an ongoing relationship with someone who knows you deeply and understands your health issues is hugely beneficial to your health.
Thank you very much. Thank you.
Great questions. I have Ramon, I have David. I just wanted to ask a quick question myself, and I think we've asked this before, Dawn. We tend to focus on the insurance side to try to contain costs. Have we worked with the insurers to work on the providers? Because the medical inflation is coming from the providers, pharmacy inflation's coming from our pharmacy benefit managers, right? Once upon a time, a long time ago, before I started on the board, we had like 3 HMOs, and it seemed like costs were not well contained even then, right? Because we thought we would contain them by keeping it smaller. So then we opened it up to however many we have now. I don't see how we're not including, and I know that that's not our purview, but how do we make that our purview, right? To see if we can control those costs.
It is our purview, and we do it sometimes. We do it selectively. So part of what we delegate to our health plans are those relationships and securing high quality, low cost provider contracts. There are numerous instances where we go in and micromanage, for lack of a better term, those relationships. We're actively having that conversation with Anthem and their relationship with some of the higher cost providers on the PPO side as we speak, because we think that is one of the tools that we need to more aggressively use to bring down PPO costs.
Well, one of them was, I think, we did take a stand on the PPOs, which was getting rid of.
We're not talking about the specifics, but
Yeah.
yes, we've been talking about eliminating some very high cost providers from the PPOs. Two examples of where we did that are, again, Monterey and Santa Barbara. So two of the highest hospital cost counties in the state. We worked with an insurer, with Trio, again, in their entry, to transition as much out of those hospitals as possible and into ambulatory sites of care where quality is as good or better and where costs are significantly lower. So that's another way that we put pressure on high cost providers. We look to move people out or provide alternative. Our reference pricing program is another great example of that, where we identify the high quality, low cost provider and bring cost sharing to close to zero for our members who choose to use those, and expose them to more cost sharing when they go to lower quality, higher cost sites of care. So those are some of the ways that we both put pressure on those relationships, and then we do actually go in and in many cases and say, no, that's not good enough. One of the challenges is that the highest cost providers are often the only providers in an area, and so this is the harm of consolidation that I alluded to when I was speaking with Ms. Cohen, that when we get down to a situation where there's a lack of competition, it's very hard to put that kind of pressure on a provider, because there is really just no alternative for our members.
So, and then of course we still have the out-of-state workers and retirees, but I'm more concerned about the workers that are out of state, where they only have the choice of the PPO. And I assume we continue to put pressure on the providers every year, correct? As to the best of our ability.
We do.
Okay, and so I'm gonna move on. So we're dealing with healthcare rates. Ramon, go ahead.
Thank you, President Taylor. Yes, I want to commend Controller Cohen and also the colleagues here and the public testimony about expressing the correct questions and expressing the frustration we have over the situation on affordable and accessible rates. I also wanted to add to Mr. Mullen's comments. CalPERS has done some innovative things, I think, since I got on the board. One of them is this very recent, is where we try to narrow the scope of bargaining by ensuring that the rates when initially submitted are appropriate, meaning as close to justified as possible. And we do that by having their plan actuary for the various carriers sign off a test that it was basically actuary appropriate. So there's not that big coming high, coming low. And that's why we were happy to get some movement from Anthem, but the other ones it's hard to do. So that's one thing, I think. The other one was alluded to, which is introducing narrow network, high-quality networks like Blue Shield, Trio, and United Healthcare Harmony. Those happened very recently, and I'm glad those are coming in, and I'm glad they're expanding. We want to expand. But I do also want to speak to Kaiser. I mean, one thing that Mr. Moe said is Kaiser, we see it as an efficient provider, which is true. And HMOs tend to be more efficient because of managed care and primary care physician, and they can track your progress. But I think two things have to be said here. One is, Ms. Controller Cohen alluded to it, the previous CEO for Kaiser had made a public pledge that he wanted Kaiser to be the lowest price HMO. I don't think that's still there. But the other thing, though, is that we are doing different things to our PPO arenas where we're trying to add a small measure of, I don't want to say managed care, but directing people to choose a primary care physician. There's incentives because we care, and that's the other thing I think is very important. We care about the outcomes, the medical outcomes, not just choice where people can go here and there, but outcomes where the health is coordinated. And I think today we're going to hear some presentations about evidence, medical, I'm not sure the term, but health population and what's the correct evidence as to how to do outcomes and how to address comorbidities with when you have somebody reporting to their doctor, but they can also indicate depression or other comorbidities, so everything can be addressed. So I think those are some of the things that I'm proud of that, besides the data warehouse that we talked about, that we can build up the rates on, that we're moving forward to. It's a complex situation, and I'm just glad we have the staff here that can provide some of the guidance and some of the experts outside of this room that we contract with, like whole things about what is working, what isn't, and this whole thing about this. We're struggling with what is the right risk mitigation strategy, but I think we're getting there because we want to reward people for the quality of care, not necessarily whether they can reward them for attracting the young and invincibles who don't go to the doctor, but they can make big profits on. So I think we have to balance out the risk pools, and I think that's something that we're doing very well. Nonetheless, there's a lot of frustration, and justifiably so, because the rates are the way they are. And unfortunately, that's the system we're dealt with, where we have insurance carriers that do not necessarily provide the health. They contract with medical groups. And so the same medical group, the same doctor may be well contract with more than one more than one insurance carrier, but that's what we're dealing with.
Yeah.
So thank you. I think I spoke too much, Ms. Taylor.
You know what, Mr. Rubalcaba, I appreciate your knowledge and sharing that with us. Don, real quick before I move on to David, I remember 2 months ago, I think, May, that we had talked about cutting off new member access to Kaiser. And we decided, I don't know if you want to talk about that a little bit, we decided against that as a cost-cutting measure.
I mean, so it would be less of, I think, a cost-cutting measure and more of a punitive measure. Yeah. The challenge is that, well, there are two challenges that are significant. The first is that typically our youngest and healthiest members are our newest members. And because CalPERS members are sticky, when they choose a health plan, they tend to stay with that health plan. If we were to do that, we would significantly change the risk pool for Kaiser, which would immediately and over time make it even more challenging for them to come back down to earth. The other problem is that in our retention and recruitment of public agencies, many of them come to us because we offer Kaiser. And so it would be in talking with our folks who work with the public agency community, they expressed extreme reservations about both the ability to retain public agency members and certainly to recruit any new public agency members if we were to cut off Kaiser for new members. So it was, you know, it's I think at the end of the day it would be a statement, but it would have certainly detrimental effects on our Kaiser rates and on the PA side for us.
So ultimately, it could impact the Kaiser rates negatively. Is what you're saying.
Negatively, and yeah, we did not recommend it.
Okay,
Yeah.
thank you so much. David?
Yeah, I guess I'll start by saying I share everyone's frustration with this, but I do support staff's recommendations at this point. It's one of those kind of bite your lip and you know, deal with the current reality. But I have like 3 things I want to touch on just as ideas and thoughts. Teresa touched on one, which is curtailing somewhat going forward with new members, our relationship with Kaiser. One of the things that kind of strikes me is, you know, when in terms of this whole price elasticity of demand kind of thing, where the prices when we're having outside consultants suggest to give us information on that, I think, you know, asking our members might be a good idea, you know, at what point, but we know they're sticky, but knowing they're sticky also means putting new members into that sticky situation, aside from being you know, kind of posturing in a way. But it also, if we're trying to promote things like Trio and Harmony, would seem to be a real boon to have new people, and whether it would have to be done statewide or whether it could be done on a geographical basis, say, maybe that is a strategy where there are alternatives, where they're going to be the sticky alternative where new people go versus Kaiser. So something, you know, thought there. All over the country, community hospitals have been blinking out right and left. Some of them just blink out and are gone. Communities don't like this trend. I don't know that we like this trend, but certainly other big healthcare organizations and private equity firms and stuff love this trend. They're buying them up like crazy. The rise of the community-based outpatient clinics, starting way back in the 80s with the VA, demonstrated that this is a good way to deliver, especially routine healthcare. But it also clearly is not the best way to deliver a lot of specialty healthcare that's outside of the scope of practice of a lot of these kind of organizations. And that's where PPOs can come in a way that it's not surprising that oncology is one of the things that people go outside of network for, whether it be to a high-cost provider that we don't like Stanford, or Catholic Healthcare West Center of Excellence for Cancer in Bakersfield, things like that. But for these, it's also not surprising that people go outside of network, especially at somewhere like Kaiser, for behavioral health stuff. I mean, just anecdotally, talk to a lot of people who have Kaiser, but who are getting their behavioral health services from someone other than Kaiser. And they're just eating the cost. They're just paying on their own. So those kind of things also are just kind of beyond insurance kind of discussions about the quality and cost and performance of our healthcare providers. And, you know, I would suggest that perhaps if we're looking for opportunities to A, get under the hood directly and learn more about this stuff, and B, look for alternative investment opportunities, things like community hospitals that are trying to hang on and that communities want might be somewhere that we look at investing. The long-term care industry is another industry like that, where the margins are low, but they're very attractive to private equity, and we're interested in private equity, and we're interested in those kind of services in healthcare where we would finally be under the hood. So some crazy thoughts to finish off my day.
Thank you, David. Okay, Frank, go ahead.
Thank you, Madam President. You know, since the preliminary release of these rates in June, the Treasurer has received numerous comments, and you can probably guess the comments have not been positive, so to speak. And she does agree or concur with the idea that $1,500 is not a modest increase, by the way. But what she does agree that, or concur with that the $1,500 is not a modest increase. It's in some cases a real hardship for some of our members. But I wanted to ask, as was suggested by Director Walker a minute ago, about the 2 years phase-in. I would like to ask staff what would be the consequences or the adverse consequences of that.
Yeah, that's a good question. So, so the two-year phase-in, as Rob pointed out, would increase HMO rates by 2% instead of 1.2% for 2024. The net effect on individuals with an HMO, so that's hundreds of thousands of our members, would be in the range of $70 for an individual up to about $200 for a family. So that would be an impact that would be felt by almost everybody in our HMOs. So so the 5,000 that Rob is talking about, who hit the out-of-pocket $500 and $1,000 threshold, some subset of those 5,000 would see additional cost sharing, but all hundreds of thousands of the other members will have an additional $70 to $200 a year added to their health care bill. So it's there is potential larger exposure to some subset of those 5,000 people, but the rest of the HMO for members for 2024 would see that 70 to 200. Now, just in the interest of going one step too far, we are talking about extending this out over 3 years instead of 2. So, so if you do this in 2, we are done in 2 instead of 3. So ultimately, it will be essentially the same number, but this is a hard year for rates, and these are very high rates, and that $70 to $200 is a lot to add on in a year like this.
Did that answer your question?
Yes, I'm trying to understand the 2 years or the 3, that's for the future there, because that's not part of the motion.
No, so that would be the direct effect in 2024, for 2024 rates. So if we went with the 2-year phase-in, the effect on premiums, out-of-pocket costs for the hundreds of thousands of members who have an HMO would be an additional $70 to $200.
Correct. And is that part of the motion, Mr. Chair?
No.
Well, the chair is
It
President
is
Taylor,
not
but.
part of the motion.
Phasing out, but that's
It's the
fine.
3-year phase-in, with minor modifications, or not minor modifications.
Okay, thank you.
Yeah, thank you. All right, Dr. Willis? Oops.
Good morning. I just have a brief question. Did the current CEO, Gregory Adams, have input with the negotiation? If so, what was specified?
He was not the individual we were negotiating with, but decidedly part of the negotiation. So these were all brought back to the executive committee at Kaiser, and because we're their largest client, it's there were multiple consultations with them. And,
So he was on board with it?
I cannot speak for him. I can speak, I mean, he's the CEO of the organization, and the organization is on board.
Okay, thank you.
Thank you, Ms. Willis. So, I think we've got all our questions from the board answered. We got all our public comment, and we have a motion on the table. Christina's gone. Kayla, can we do a roll call vote, please? Oh, where's Swan? Oh, there he is.
David Miller,
We already had a second.
Aye.
Controller Cohen,
No.
Frank Rufino,
No.
Lisa Middleton, Arena Ortega, Jose Luis Pacheco, Kevin Palkey, Ramon Rubacaba, Yvonne Walker, Melissa Willett, Dr. Gail Willis.
No.
Motion passed. We will move on at this point. Thank you, Rob. Let me see, what time are we at? We're a little behind. Pardon me? 6 to 5. Motion passes 6 to 5. I just want to we're going to move on to the 2024 state annuitant contribution formulas and association plan premiums, which is kind of an actuarial mess, but my research department at my local would love to hear it. However, before we move on, I think Don explained it, but not passing the rates in July has a hugely detrimental effect. So I'm thankful that we made this, because we might have to call an emergency session if we didn't. But I don't know if I need Don to repeat why it would be hugely detrimental, because I heard a lot of people upset that that we did pass it. So Don, if you could explain one more time what the consequences to our members are if we had not passed these rates.
The consequences are complicated, but essentially we have to pass rates in order for them to have health care.
So then the members may end up with health care rates because we didn't pass rates if they stayed in the same plan.
This is our contract with our health plans for 2024 to provide health care to our 1.5 million members. If we do not pass the rates, they do not have access to health care.
They do not have any access to health care. Okay.
Correct. If we fail to pass rates, that's
okay. I just wanted to make sure that people were clear on that. Ms. Walker, go ahead.
Yes, Madam President. I just wanted to be clear that I was not voting against the rates. I was voting against the plan design changes. I was not voting against merging the pools. I do believe we should merge the pools, but I felt it should be 2 years and not 3.
Okay,
So this is an information item, not an action item, on the 2024 state employer annuitant contribution formulas and the association plan premiums. The employer contributions for state annuitants are based on the final health plan premiums you just approved. The contribution amounts and premiums have been provided to you and are also available on our website. This table summarizes the state employer annuitant contribution formulas that are described in the agenda item. To calculate the contribution amounts for the 190 basic and Medicare formulas, as well as the 80/80 basic formula, we use the premiums from the 4 largest basic health plans. For the 190 basic and Medicare formula, the 4 plans with the most basic members are Kaiser Permanente, PERS Platinum, PERS Gold, and Blue Shield Access Plus. For the 80/80 basic formula, the 4 plans with the most basic members are Kaiser Permanente, PERS Gold, UHC Alliance, and Blue Shield Access Plus. Then to calculate the contribution amount for the 80/80 Medicare formula, we use the premiums from the 4 largest Medicare health plans. Those are PERS Platinum, Kaiser Senior Advantage, UHC Group Medicare Advantage, and the California Association of Highway Patrolmen plans. Based on your approval of the 3-year phase-in, here are the 2024 state annuitant contribution amounts by formula and plan tier. For the 190 basic and Medicare formula, the single party state contribution is expected to increase by about 11%. For the 80/80 basic formula, the contribution is expected to increase about 8%. And for the 80/80 Medicare formula, the contribution is expected to increase about 10%. We will skip slide 4 as it showed the amounts under a 2-year phase-in. So now to the association plans. As a reminder, CalPERS does not administer these plans, and their premiums have no budgetary or financial impact to CalPERS. The 3 associations are California Association of Highway Patrolmen, or CAP, California Correctional Peace Officer Association, or CCPOA, and Peace Officer Research Association of California, or PORAC. CalPERS does not negotiate the benefit designs for these plans. Each association is responsible for ensuring that their premiums and benefit changes are appropriate and the reserve funds are adequate for their continued operations. For next year, the only association benefit design change is with CAP. They are increasing the number of chiropractic and acupuncture visits allowed from 20 visits per year to 30 visits per year. Here we show the overall statewide weighted average premium increases. For basic, it's 9 3/4%, and for Medicare, it's just under 6%. For next steps, we will communicate the contribution amounts and the association premiums as part of our open enrollment communications I walked through earlier. This ends my presentation. I'm happy to take any questions.
Thank you, Rob. Does the board have any questions? It does not look like we have questions. This was an informational item. Do I have any comments on the call or any? Okay. It doesn't appear I have any comments. So we are actually going to take a break. We ended just about on time. So it'll be 15 minutes. Let's be back at 10:47.
There you go. She got her full break. Gail.
Gail, she's happy. so we're going to start the next section, which is with Dr. Julia Logan and Dr. Elizabeth Albera. Is that correct? Albers, I'm sorry. Okay, hold on, let me get out of this. 1 second. Making sure I'm in the right place. Okay. So I want to make sure everybody's sitting. We got almost everybody here. We still have some conversations going on. Our next session is an update on the work being done to advance our members' health outcomes to ensure access to equitable care, including behavioral health. So thank you on that. This is a two-part presentation with Dr. Logan, our Chief Medical Officer, Dr. Lesser, our medical consultant, and Dr. Albers. I don't know why I have this here. Sorry, guys.
I'll be introducing her, so it's
okay. So I'm seeing this name going, where is that person? So take it away, Dr. Logan. Thank you.
Thank you. Good morning, President Taylor and members of the board. Julia Logan, CalPERS Chief Clinical Director. We're excited to talk to you this morning about CalPERS' approach to population health and how it relates to our work on health equity and to improving health outcomes for our members. I am joined today by Dr. Lisa Albers, who many of you first met at our stakeholder forum in January, where she was a master moderator for our health session. She joins us from the Department of Healthcare Services, where she led their quality improvement work with their Medi-Cal managed care plans. Here at CalPERS, Dr. Albers has been incredibly busy leading much of our population health and clinical quality work. Before I hand it over to Lisa, I wanted to briefly walk through the agenda this morning. We'll start by discussing who we are. What does our CalPERS membership look like when we review the demographic data that we've been collecting through the Health Demographic Profile? We'll also talk through an example of how we use demographic data to identify gaps in care for particular populations using one of our new quality measures. We'll cover exactly what population health is and how our work on population health and health equity support each other and our strategic goals. We'll provide an update also on our behavioral health data and activities. And finally, we'll talk a little bit about next steps before answering questions and hearing your important feedback. We look forward to a really good discussion. With that, I'll pass it to Lisa.
Thank you, Julia. Hello, President Taylor and members of the board. So I want to first begin by reviewing our strategic health plan, as it's that which informs the development of all of our health initiatives, including our population health management framework. Throughout the presentation, we'll talk today about how our population health-based quality measures help to drive quality improvement and ensure high-quality care and better outcomes for our members. We'll also talk about how a population health approach is pivotal to providing equitable care. We'll talk about how our population health framework, which includes the integration of advanced primary care and behavioral health, help to improve access for our members. And finally, we'll briefly discuss how value-based care and payments are paying for quality rather than volume, which is a part of any population health approach, can increase health equity and affordability. Next slide. Thanks. As I just mentioned, ensuring our members receive the most appropriate high-quality care when and where they need it is what drives our strategic health goals. To understand the care that our members need, we first have to understand who they are. So thanks to our health demographic profiles, we continue to expand our understanding of our members. As a quick reminder, the health demographic profile is a series of 9 brief questions that gives members the opportunity to tell us about their race and ethnicity, their written and spoken language, their gender identity, and their sexual orientation. And that helps us have a more complete picture of our membership. With this information, we'll be able to detect gaps in care and ultimately build strategies targeted to particular populations and their unique needs. So far, we've analyzed approximately 174,000 profiles. Of these, 116,000 are for basic members and 58,000 are for Medicare. On the next few slides, we'll take a look at the data broken down by several different demographic categories to give you a profile of our CalPERS membership based on the data that we've collected so far. I do just want to note that we're in the early stages of this data analysis, as well as in the early stages of the data collection. With our new health plan contract requirements to gather and submit demographic data on their members starting in 2024, we expect the amount of data that we have on our members to grow, and with it, our ability to do further and more detailed analyses. Here on the slide, you see the race and ethnicity breakdown for our membership, and this is based on results from the health demographic profiles. It's for adult members only, so ages 18 and up. Our adults in the basic program are represented by the green bars and those in Medicare by the blue bars. You can see there's a difference in the distribution of race and ethnicities between our basic and Medicare populations, with our basic population appearing more diverse. The data seems to indicate our membership is increasing in diversity over time. I do want to define the last two groups on the slide, on the left-hand bottom part of the slide. There are two categories there. The multi-race category is defined as individuals who selected more than one race. The other race category includes individuals who identified as American Indian or Alaskan Native, or as other, or as I don't know. These groupings help us to generate sample sizes that are large enough to conduct the analyses on and share publicly. Otherwise, some of the categories would be too small to include. Next slide. Here you can see the breakdown for gender identity for our adult members, also based on results from the health demographic profiles. The blue bar again represents Medicare and the green bar basic. The numbers are fairly consistent between the two populations in terms of gender identity. The collection of accurate and comprehensive data on gender identity helps us to identify disparities in this population, and it can help healthcare providers deliver more inclusive and culturally competent care. We know that transgender persons face increased barriers to care compared to other populations, particularly in finding providers that have experience in treating them. So this information can help us make data-driven decisions, target interventions, and then develop programs or policies in response. Next slide. Here you see the breakdown for sexual orientation for our adult members, also based on results from the health demographic profiles. The graph displays both Medicare and basic health plan members, and again, the blue represents Medicare and the green bars basic. The results are consistent in terms of sexual orientation between the two groups. Again, we just want to stress that being able to understand our members' demographics allows us to work with our plans to develop appropriate services based on targeted gaps, hopefully ensuring that no one goes without the care they need. Next, we'll look at the geographic distribution of our members. So one of the things that we consider when looking at member experience is if the experience differs by geographic distribution. On this slide, we use data from our health plan member survey analysis that uses a population density index based on member zip code. We see that the majority of our members live in suburban and as well as urban areas. You can also see that for those members living in areas defined as rural, most are in the PPO rather than the HMO. And that highlights the importance of this offering to our members that live in areas where choices, at least historically, have been somewhat more limited, though that is changing. Now that we've shared some basic demographic data on our members, we'd like next to look at the chronic health conditions that we see most commonly in our members, because it's the prevention, the diagnosis, and the management of these diseases that is much of what our population health approach focuses on. So here you can see some of the most common chronic conditions that our CalPERS members experience based on claims data from our data warehouse. Not surprisingly, obesity, high blood pressure or hypertension, and diabetes are among the most common, with approximately 28% of our members having obesity or being overweight. That rate is actually lower than national averages, but is consistent with California averages, as California typically does have a lower rate than the rest of the US. Approximately 11% of our adult population has high blood pressure, and approximately 8% are living with diabetes. Now we'll look at the costs associated with treating these diseases. So on this slide, you can see that the total cost of care for preventable chronic conditions such as diabetes is incredibly high, and that the management of chronic conditions in general is driving an enormous amount of our healthcare spend. I would note that the cost here includes both the medical and the pharmaceutical care of these conditions. You may notice and wonder why obesity isn't on this list. The reason is that the method that we use to calculate the total cost of care for conditions that you see on this slide, it isn't as accurate at estimating the cost of care for obesity. That's because obesity is closely tied to comorbidities or co-occurring conditions like high blood pressure and diabetes, and it's often treated as a secondary issue to these other diagnoses. So then it can become difficult to distinguish the true cost of treatment for obesity for some services like doctor's visits when multiple conditions exist simultaneously. We are, however, working with our data warehouse staff and with our consultant partners to try to get a number for that. What is very apparent from this slide and the previous slide showing the percentage of our members who have these common chronic conditions is the enormous impact that these diseases have on our healthcare program. That's why, as we'll discuss later, we have focused on a narrow set of population health-driven quality measures to try and target some of these conditions and improve upon the diagnosis and management of them. It's also why we are prioritizing population health management, particularly complex care management, in the PPO solicitation. We will also talk about that in a few slides. Now, though, I'd like to walk you through an example of how we plan to use our demographic data, the data we discussed earlier, to look at our quality measures in more detail and to hopefully better address needed improvements in the care of particular populations. Just one more time, though, before we dive into these slides, I want to note that we're still in the early stages of working with and analyzing this data. And so we're keeping an open mind as more data becomes available and we refine our analyses. Okay, for our example of how we're going to look at our quality measures using demographic data, we will focus on colorectal cancer screening or colon cancer screening, which is one of our high priority quality measures in the new HMO contracts for 2024. To assess colon cancer screening in our population, we use the nationally recognized colon cancer screening performance measure developed by the National Committee for Quality Assurance, or NCQA, which is sort of the warehouse of most of the nationally recognized quality measures. It measures the percentage of members of an appropriate age who had appropriate screening for colon cancer within the specified time frame. Early detection of this disease is critical because survival rates are much higher at earlier stages of the disease. So with localized disease, meaning confined to the colon, people can experience survival rates of upwards of 90 to 91%. But once it's spread distantly, then survival rates plummet to as low as 13%. So it's very important. As you can see in the slide, our 2021 screening rate for Medicare members is about 55%, while our rate for basic members is about 66%. For context, the national colon cancer screening rate per the National Colorectal Cancer Screening Roundtable was 69% in 2020. Now, starting in 2024, our HMO plans will have to meet the 66th percentile for all commercial plans nationally, a benchmark that's developed by the NCQA. In 2022, that 66th percentile was 69% as well. So you can see that our plans have some work to do, and we with them. And of course, we don't want to stop at the 66th percentile. That's the floor, that's not the goal. We hope to continuously improve and eventually do much better than the 66th percentile. Next slide. Now, using the same measure, we can look at the results for our Medicare members by their race and ethnicity. As you can see on the slide, Medicare members who identify as white were screened less than other groups, which does seem counterintuitive based on historical national disparities for colon cancer screening. But that may be changing. Additionally, this is exactly why we do these types of analyses. For some measures in certain populations, the groups experiencing a disparity may not be who you think. Looking at results for the basic population now, you can see that American Indian or Alaskan Natives are screened less frequently than other groups of basic members. I wanted to point out here that our health demographic profiles actually have the option for many more granular race and ethnicity categories than what you see on this slide. Numerous subcategories for Asian members, for instance. However, the numbers of members reporting out as those more detailed or granular categories are too small for us to reliably report on at this point. So we rolled them up into these broader categories in order to be able to share publicly. Next slide. Here we see the same colon cancer screening measure stratified by sexual orientation for the basic population. Here, lesbian, gay, bisexual, queer, and do not know responses were grouped to ensure adequate sample size. This group and the heterosexual group are performing similarly for this measure, with both being screened around 70% of the time. However, our hope is that as we collect more profiles and as the plans collect their member demographic information, we'll be able to disaggregate or separate some of these categories into their smaller subpopulations and uncover any disparities that may be lurking there. I also want to point out that there wasn't enough data to do this same analysis of this demographic category for Medicare members, so that's why you only see it for basic. And here is the same measure stratified by gender identity for the basic population. Here we have categories for male, female, and then grouped together, transgender, non-binary, and other. As I mentioned earlier, stratifying these measures hopefully allows us to track progress towards reducing disparities, improving health outcomes for all of our members, regardless of race, ethnicity, gender identity, or sexual orientation. And then the last thing I wanted to say about our initial analyses here is, again, it's in early stages, and the reason for that is we only very recently achieved the required number of health demographic profiles to do these analysis at the beginning of this year. And in some cases, for smaller groups of individuals, as we just talked about, certain race or ethnicities, certain gender identities, we still don't have enough member information to accurately stratify. But we are hopeful that with the new health plan contract requirements around the collection of demographic data, as well as our continued collection of the health demographic profiles, that our ability to stratify will only continue to improve. And we look forward to sharing those results as we're able. So now we're going to transition to a discussion of population health, what it is and why it's important for our CalPERS members. So population health is a patient-centered approach that aims to improve physical and behavioral health outcomes, promote well-being, and reduce health disparities across an entire population using data to drive decision-making. Put into very simple terms, population health is an approach to healthcare that focuses on improving the health outcomes of a group of people rather than just individuals. The group is simply a group of people with something in common. So it might be members of an employer, or patients in a healthcare system, or people in a particular geographic area. Population health is important to CalPERS health program because it supports so many of our strategic goals, including ensuring our members receive high quality, equitable, and affordable health care when and where they need it. Population health is meant to promote better health outcomes and cost-effective healthcare delivery for our members. On the next slide, we'll discuss our approach to population health. So our CalPERS population health framework helps to drive our strategic planning, it helps inform our health plan contract requirements, and it aims to provide our members with access to a comprehensive set of services to meet their needs. It's designed to ensure that members have access to services based on their needs and preferences across the continuum of care, resulting in healthier, longer lives, improved outcomes, and health equity. Our framework consists of the following key principles: a patient and family-centered approach to whole person care, coordinated and integrated physical and behavioral health care that hopefully reduces siloing and fragmentation of care, culturally competent and equitable care, including looking for disparities and then developing interventions to eradicate those disparities, using data to drive all of the above, including the identification of gaps in care, and finally striving to enhance care delivery while continuously improving upon health outcomes for our members. Population health management is conducted, or it's done by using data to first know your population, such as their demographic characteristics, and then to identify the level of need or risk of one's members. It provides a spectrum of care, ranging from basic population health to complex care management and to the highest intensity care management for the most medically and socially complex members. Basic population health management is meant to improve health outcomes for all members through the provision of preventative care, health education, and management of routine chronic diseases. It's really reliant on and driven by primary care. Complex case management, or complex care management, coordinates services for members with complex conditions and helps them access needed resources. It's designed to more effectively assist patients and their caregivers in managing medical and behavioral health conditions. It's team-based, it's patient-centered, and it should provide comprehensive and integrated care. Finally, high-intensity care management is generally for a small group of the most medically and socially complex, highest-risk members in a population. It offers comprehensive coordination and management of their medical, behavioral, and social services needs. And of course, any person may move up and down that spectrum throughout their life. They may need additional services during acute periods of their lives, and then they may need less at different periods. So it's important to routinely assess and reevaluate the needs of each person. So to sum up, the goals for our population health program are to improve whole person care for CalPERS members, promote behavioral health integration with physical health care, particularly primary care, reduce health disparities and close gaps in care to improve health outcomes, and finally, to make meaningful advances in quality in the healthcare delivery system that positively impact patient outcomes and experiences. The next couple of slides describe how we've implemented some of our population health strategies and how they reinforce our initiatives to advance quality and care integration. So our health plan contracts are one of our most important levers for change and improvement. For this reason, we made a very concerted effort to strengthen and prioritize our population health requirements in the 2024 HMO contracts. There are 4 areas that really impact population health in the contract: care, disease management, behavioral health, health equity, and quality improvement. For care management, we strengthened the population health requirement by requiring that our plans submit the same population health strategy that they submit to the NCQA to CalPERS for our review and approval. NCQA's health plan accreditation, which all of our health plans must have starting in 2024, requires that the plans have a comprehensive population health management program in place that's able to identify and stratify all members into risk categories, ensuring that members who are medically or socially complex or at risk of becoming so receive the care that they need. And it also requires plans to offer differing levels of intervention, like we just talked about, depending on each member's needs. We also expanded our requirements around care transitions. Members transitioning from hospital or to home or from a nursing facility to home are at particularly high risk of not getting the care, services, or resources that they need, such as follow-up appointments, medications, or durable medical equipment. So we really tried to strengthen the requirements around the management of this vulnerable time. With regards to behavioral health, we strengthened contract requirements for access by requiring health plan submission of their NCQA Behavioral Health Network reports, which Dr. Logan will talk about in just a few more slides. And finally, in order to promote equity, we've instituted a new requirement that all of our HMOs and PPO plans achieve NCQA Health Equity accreditation. That's to ensure that they have in place the processes necessary to identify and address health disparities. Similar to the Department of Healthcare Services here in California, we also included a contract requirement for each of our HMO health plans to create and maintain a member advisory committee. The member advisory committee must be representative of CalPERS members, and these committees will help in getting feedback directly from members to the health plans to improve access and quality of care, culturally appropriate services, and member engagement and experience. Before we talk about quality, I just wanted to talk very briefly about the upcoming PPO solicitation and the proposed requirements to bolster population health in the PPO, since we just spent a lot of time talking about the HMOs. Just as we made changes in our HMO contracts to promote and prioritize population health, we'll be making similar changes in the upcoming 2025 PPO solicitation. With the PPOs, we're very aware of the need to work not only on cost containment, but to also focus on improving quality of care. We're going to step further by prioritizing care management
infrastructure related to behavioral health. Further, it recently awarded $23 million to expand the state's behavioral health workforce, as well as $30 million to groups to support youth mental health. Grant programs like this are so important to help grow behavioral health organizations and to assist with attracting a diverse workforce and to grow the behavioral health workforce pipeline to reflect the needs of the communities they serve, and they will positively impact behavioral health care and access for all Californians. In the next few slides, we'll talk more about behavioral health in particular, a crucial component of any comprehensive population health management program. I wanted to dig into our behavioral health priorities and some of the work completed in our HMO RFP to drive improvements in behavioral health. The first is around quality. As Lisa noted, we've implemented requirements on a common set of quality measures. We believe that aligning with our purchaser partners on these critical population health measures we will collectively be better able to drive improvements by focusing plan and provider efforts and minimizing administrative reporting burden. Next, I wanted to talk about access. We've directed plans to offer telehealth services to augment in-person care when clinically appropriate, but especially for behavioral health care appointments and follow-up. As you know, telehealth is an essential tool in improving access, and our experience with providing telehealth through the pandemic has proved it to be an indispensable resource for individuals seeking behavioral health support. We are leaning into telehealth for behavioral health services because it improves access, and mental health and substance use services really lend themselves to telehealth. However, we really need to be sure that the quality of the services are as good as or better than in-person services. To this end, we're working with RAND to better understand how telehealth services measure up in terms of quality and member experience, and look forward to sharing the results of that study when it's complete. And Dr. David Cowling will also be talking more about this in a few minutes. Additionally, our plans will be required to submit their NCQA Behavioral Health Network Management reports to CalPERS for our review. We're working with Covered California to review those submissions in tandem to identify access trouble spots across the state and across plans. We know that without equity, we will not achieve our goals of high-quality behavioral health care. We're requiring our plans to collect and report self-identified health demographic data, as you know. And through the new HMO contracts, we will be working with our plans to improve provider proficiency around LGBTQ health and cultural and linguistic competency. We're also working on improving our provider directory tool by including additional information on our providers and working with our plans to do the same, empowering members to find providers they can be comfortable with. When members feel comfortable with their providers, they're more likely to build relationships that improve health outcomes. And we participate on the Department of Managed Healthcare's Quality and Health Equity Committee, which will be requiring quality and health equity measures and benchmarks of all DMHC-regulated health plans in California. And we also participate on the DMHC Transgender, Gender Diverse, or Intersex, or TGI, Healthcare Quality Standards Working Group. The charge of this group is to develop a quality standard to measure cultural competency related to the TGI community and recommend a trans-inclusive training curriculum for health plans. We have increased reporting on the integration of behavioral health and primary care in our new HMO contracts, and we also continue to work on the advanced primary care measure set and pilot, and are requiring all health plans to report on the number of members served by advanced primary care models as part of the RFP, similar to Covered California and the Department of Healthcare Services. Now we'll walk through some updated data on prevalence of behavioral health conditions and utilization of behavioral health services. And you'll remember some of these slides from my update last year at our offsite. The first slide is our behavioral health prevalence data from 2019 to 2022, broken down by basic members and Medicare members. Last year, we discussed that there had been a steady increase in the prevalence of behavioral health conditions for both commercial and Medicare members over time. However, it appears to have leveled off out leveled out just a bit this year from last year. There are even a few slight decreases, but the changes really are quite small. For reference, 8.4% of U.S. adults reported a major depressive episode in 2020. Sorry, I added 20, I think. Per the National Institute of Mental Health. Of note, the U.S. Preventive Services Task Force has just issued a recommendation for universal screening for anxiety in adults and children. With this new recommendation, I suspect that we may see an increase in anxiety prevalence over the next several years as clinicians start screening their patients more broadly for anxiety. I do want to keep a spotlight on adolescent behavioral health, specifically because this age group continues to struggle profoundly, whether due to effects from the pandemic and social isolation or trauma, approaching adulthood in very tumultuous and uncertain times, or other factors like social media, as was recently highlighted in an advisory by the U.S. Surgeon General. While the data thankfully don't show an increase since 2021, they still do show an increase in prevalence in 2019. We continue to work with state partners and health plans to create a whole child approach to access and care for these members. This slide combines basic and Medicare outpatient behavioral health utilization. So this includes all counseling visits and clinician visits for medication management, for example. As you can see, after remaining relatively stable throughout 2019 and early 2020, we have seen a steady increase in utilization throughout most of 2021, and then another increase in early 2022. This slide highlights the use of opioids and medication-assisted therapy for 2019 through 2022. As a reminder, medication-assisted therapy, or MAT, is the medication used to treat opioid use disorder. Consistent with state and national trends, fewer members are utilizing prescription opioids, and the volume of prescriptions continues to decrease, which is good news. Utilization of medication-assisted therapy continues to increase by about 37% from 2019 through 2022, which is also good news that those with opioid use disorder are getting the care that they need. In addition, we haven't noticed an increase in member grievances related to opioid prescribing and treatment. We observed a decrease in prescriptions for rescue therapy called naloxone, but that may be a reflection of the decrease in opioid prescriptions and the availability of naloxone without a prescription at pharmacies and other naloxone distribution centers, though we're keeping an eye on this rate as rescue therapy is a crucial component of opioid therapy. Based on our data, it appears that our CalPERS members are experiencing thoughtful prescribing and have good access to MAT. As you're aware, we've been monitoring telehealth utilization throughout the pandemic and afterwards because it can be a useful resource in mitigating access challenges and meeting increased needs for behavioral health services. All age groups showed a dramatic increase in the use of telehealth at the beginning of the pandemic, which has leveled off for most groups at this point, except notably adolescents, though utilization continues to be much higher than it was pre-pandemic, indicating that this care delivery method is here to stay. In addition to making our HMO contracts, making HMO contract changes to further promote behavioral health integration and improve quality and access to care, we also focused on member engagement. We know member experience is crucial because a positive experience contributes to better outcomes for individuals seeking behavioral health care. Based on our behavioral health access study conducted by UC researchers in 2021 and 2022, we also know that our members reported not understanding what behavioral health benefits were available to them or how to access those benefits. Members reported a lack of transparency around behavioral health benefits, including confusion about what services are covered and not covered, co-pays, and the availability of providers. Navigating the insurance process to obtain services was emotionally taxing and time-consuming, and members expressed that they didn't know where to start. Specifically, our analysis showed that members need more education on what benefits they have and how to access these services they are entitled to, and that each plan should provide a list of steps for navigating and accessing behavioral health. As a result of these recommendations, we engaged our health plans in a behavioral health benefits education campaign for our members. Each health plan developed an email and hard copy flyer to send to all members describing mental health and substance use disorder benefits, including any digital apps or platforms used by the health plan, how to access those benefits, including virtually, and who to contact if members were having difficulty finding a provider or making an appointment. Specifically, we had the plans include a phone number to reach a live agent for assistance. These communications went out last month to all members. At the same time, CalPERS also sent out information to all members notifying them that they would be receiving this information on how to access behavioral health benefits from their health plan. We hope this coordinated effort will make it easier for members to access these services in the future and provide members with ready access to assistance in accessing these services. We'll continue to work with plans to ensure that our members are aware of their benefits, how to access the services, and who to contact if experiencing difficulties. Our last action item in furthering our goals around behavioral health and population health is the promotion and support of integrated care models such as advanced primary care and the integration and co-location of primary care and behavioral health. Our HMO contracts require plans to report on the percentage of spend on primary care, on the number of integrated primary care and behavioral health care models, as well as the percentage of providers paid by alternative payment models that incentivize quality over quantity of services provided. Plans are also required to participate in the Advanced Primary Care pilot with the Integrated Healthcare Association, which supports integrated care models as well. This will be mirrored in the PPO contracts in 2025. Again, taking these steps in alignment with our purchaser partners and working with them to establish targets for primary care spend and alternative payment models that facilitate whole person population health-based care and level of integration of primary care and behavioral health to expect from our networks. I would like to briefly mention our annual member survey results, as this continues to be an important tool to help us understand our members' experience of care. The survey contains numerous questions related to member satisfaction or experience with their health plan, providers, and their ability to access care as needed, and can help us understand access limitations in ways that our claims data cannot. For the 2023 Health Plan Member Survey results, which reflects member experiences with services performed in 2022, we noted the following. A majority of members were able to access mental health care when they wanted it. With regards to depression screening, we saw results similar to 2021. About 40% of respondents answered yes to having been asked about feeling sad, empty, or depressed. While the rate of screening increased by about 5% between 20 and 2021, it remained relatively flat in 2022. So we've added this to our behavioral health strategic measure as well as to our health plan quality measures. The Health Plan Member Survey also asks about the utilization of telehealth for behavioral health services. We saw that utilization decreased somewhat between 2021 and 2022, which may be due to the easing of the pandemic and was consistent with what we've seen in claims data. 2023 results also showed that members who received counseling and treatment were helped by their care. However, this number has declined from prior years. While we know that fewer members surveyed feel that their counseling and treatment helped, we don't know exactly why it didn't help, and we're considering options as to how to dig deeper into this issue. We also know that members are less satisfied with their care in general during and after the pandemic than pre-pandemic, and it will take some time to sort out why that is. More than half of our members continue to report that their behavioral health access is stable in 2023, though in doing our analysis, we learned that fewer members have reported that they're able to get behavioral health care right away in 2023. This trend is concerning, and we're looking at it closely. In order to better monitor behavioral health quality and access, as part of our strategic plan, we've included our behavioral health strategic measure. This will help us track our progress on behavioral health prevention and treatment delivered at an organization level. We've added behavioral health measures to both the HMO and then will in the PPO as well to ensure that health plans are financially accountable for behavioral health prevention and treatment delivered at the plan level. We are analyzing both our health plan member survey and quality measure results so that we can look at disparities in access to care as well as experience of care. We know, as Lisa mentioned, that certain groups have more difficulty than others accessing care, including finding providers with appropriate experience to treat them. So this analysis is a valuable tool to track our progress and maintain awareness of areas that we need to focus on. And we continue to monitor grievances and appeals from our health plans and our pharmacy benefit manager to look for issues around behavioral health, particularly access. While there hasn't been an overall increase in behavioral health access grievances and appeals, we continue to communicate with the Department of the Department of Managed Healthcare, a lot of acronyms, I'm sorry, regarding their specific audits of plans around behavioral health. We hope to have results from some of the plans later this year. I wanted to finish with our next steps for population health and behavioral health. Our CalPERS health team is dedicated to our mission to improve quality, access, equity, and affordability to the health care we provide our members. To this end, we will be monitoring access and the quality of behavioral health services, and we'll be working with our partners to expand behavioral health integration. We'll be focused on quality improvement through the stratification of quality measures and working on publicly sharing those findings, as Lisa mentioned. We're dedicated to holding our health plans accountable to the changes in our HMO contracts, and we'll be implementing changes in our upcoming PPO solicitation to reinforce our dedication to improving the quality, accessibility, and comprehensive care delivered to our members. Lastly, we'll continue to drive change to achieve equity by increasing data through bi-directional data sharing with our plans and by working with our partners to set disparity reduction targets based on our data. Before we open it up to questions, we want to thank you for your interest in improving the health and well-being of our members and for all of your advocacy to get us there. I also wanted to thank all of my dedicated colleagues at CalPERS who contributed to this presentation and the work that they do every day to achieve our mission. With that, we're happy to answer any questions.
So thank you for an amazing presentation. That's a lot of information. So, wow. I do have a question from our chair of our Pension Health Benefits Committee, Mr. Rubalcaba. Go ahead.
Thank you, President Taylor. Thank you, Dr. Logan and Dr. Albers. Very good presentation. I did have some questions back on chart number 9, prevalence of the chronic conditions. I was very delighted to hear these new initiatives, particularly on moving towards integrated care models, and so they can have better outcomes, and including depression screenings. So my question is on this chart. I noticed that even though you have some data on depression screenings later, depression isn't listed as a chronic condition. I always thought it would always show up as a chronic condition, as a comorbidity, but do we not screen for it at this stage? And second question, is this based on HMOs or PPOs or both?
It's a great question. It's for both the PPOs and the HMOs. And the data on this screen was done based on searching the data warehouse by a certain method that looks at diagnoses over time. And so it's a little bit dependent on how you define chronic conditions. And certainly depression is often a chronic disease, but it's not necessarily always defined that way or comes up in the data that way. So when you look nationally and at the data even that Julia shared on later slides, the prevalence for our members looks to be about, I can't remember, 5%. But for whatever reason, the way that the method was done here when looking at these diagnosis categories, it didn't come up as high. That's why we looked at it in a different way for the slides that Julia was showing.
I appreciate the answer, and I'm glad that we're making an effort to these accountability measures to make sure that that is screened also at the primary care level. My other question is on slide number 11, the cancer screening. So I gather from the presentation that one of the driving things is that it is going to be the primary care where we can do these screenings and what have you. So my question here is, I'm assuming that, I don't want to presume the answer, but did we find that your research find, looking at the data, that the HMOs tended to have better screening or follow-up on this item rather than the PPOs?
That's another great question. So first of all, the measure is only one for screening, so it doesn't necessarily look at follow-up, which is a very important thing to measure as well, but this particular measure is just looking to ensure that the initial screening was done. In terms of the PPOs versus the HMOs, we didn't break this data down that you see on the slide by PPO versus HMO. However, our HMOs and our PPOs are each reporting on this measure already for their separate lines of business, so by PPO and HMO. We have the results for their commercial book of business for 2022, and actually they look quite similar between the PPO and at least some of the HMOs. So there is variance, but it is not as high as you might imagine, at least for 2022.
Thank you very much, and I really appreciate the direction where your folks are going in, and I look forward to continued reports, and I have high hopes for this procurement with the PPO where there's new requirements, and that would be very, very good, because we care about not just price but also the quality outcomes for our members, because we want them to be taken care of, not just early in the stage of their career and their life. Thank you very much.
Thank you. And I just wanted to emphasize the PPO piece, that, as Lisa mentioned, we're carrying over so many of the HMO requirements around population health and caring for a whole population at different levels of care into our PPO solicitation. So that'll be a really important piece of it.
Thank you, Mr. Rubalcava. Mr. Pacheco.
Thank you. Thank you, President Taylor. First of all, thank you, Dr. Logan. Thank you, Dr. Ellis. Thank you for this presentation. I'm very excited about it and so forth. I want to also go back to page 9 as well on the prevalence for CalPERS chronic conditions and focus on the prevalence of the obesity part of that. Now, is this the first time we've seen this exactly, or have we seen this before in other cases?
You know, I don't think we have specified the prevalence of chronic conditions over the past few years.
And the cost, and the slide as well as number 10, the page 10 as well. So in the news, there's been a lot of headline news regarding the GLP-1 agonist medication, or as it's known popularly as the Ozempic medication. Mm-hmm. And it's been shown that people need to take it. You can reduce your weight, and it does. Of course, I don't really know all the details, but it seems to improve clinical outcomes for the persons who are taking it. Also, from my understanding, it's a medication you have to take for a very long time, but it's also very expensive. So, given this and given the costs and so forth, I see the prevalence cost right now in just treating diabetes is $458 million. Additional comorbidities like hypertension, which is associated with that, and another $220 million. what are your thoughts on that framework? If you can explain, give us some understanding on that.
Yeah, excellent question. So obesity, as you know, is a widespread chronic disease. About 40% of our membership experiences obesity. Obesity has many risks associated with it, including heart disease, early death, early diabetes, the list goes on. And so increasingly, it's recognized that obesity needs to be treated, and it needs to be treated early. That being said, some of the medications to treat obesity are incredibly expensive. They're being priced at the cost of drugs that are used to treat either acute conditions or sort of very rare conditions. They're not being priced by pharmaceutical companies as drugs that are used for chronic disease. That being said, there are 6 drugs that are FDA approved to treat obesity. Most of them are non-GLP-1s. GLP-1s are the ones that are quite expensive. So my team and I are working on a path to create access to obesity medication and thinking about how to risk stratify and really to identify those who are most at risk and to treat them first and sort of to create a whole person care approach to obesity management, because it's incredibly expensive, it's debilitating, and can cause chronic conditions. So we're definitely concerned about that trajectory.
And thank you for bringing that up, because that slides into my next question, which is actually the CalPERS Population Health Framework on page 17. That one, as you mentioned, you said your approach was going to be a whole person patient-centric approach. And so in that schema or that vision you have, are you also considering, like, I think coordinated navigated care, integrated care, like patient navigation as they call it, would that be part of that whole schema? I just want to understand if you can just elaborate more on that. Dr. Laz, yes.
Yeah, happy to. Great question. We are very much looking into care navigation services in the PPO, where we're really focusing on care management as a part of that population health framework. And so care navigation is one of the services that we will be looking for in any new bidder for the solicitation. And that's to do the things that you're talking about, to assist members with everything from understanding how it is that they get their prior authorization approved or why it wasn't approved, to helping to get appointments, to making sure that they have that follow-up with the specialist that's so needed, to helping get that medication available to pharmacy where it's accessible to them. So that is definitely a priority. We're exploring that in the HMO, but have not yet included that as a contract requirement on the HMO side, because so much of what the HMOs do, it's inherent in their in the way they're structured, is to coordinate that care for members. But certainly it's a priority on the PPO side. Yes, and I actually saw when you were showing the slide, I was very, very impressed by the, say, member navigation part of the solicitation and so forth. On that note then, on that navigation then, how does that relate to the overall, on the next slide, this is page 18, the population health management. As you mentioned, the basic population health management is associated with the primary care, the gatekeepers of the process, and it keeps on going up. Will the patient navigation framework be a one-stop shop, helping them go through the entire process? Because from my understanding, and even my own mother, I have to help her. So I'm basically her patient navigation person. But it is super complicated just to get appointments, just to put together the schedules, everything else. And I just want to understand that, because I think it goes to the core of making sure that we improve clinical outcomes for all our 1.5 million active members in this area. Yeah, another great question. Couldn't agree more. I think everybody can relate to being the default navigator for a family member or a friend in their life, without a doubt. And none of us should really have to struggle that much, either for ourselves or on the behalf of that family member or friend. So yes, the vision is that the care navigation services, as a part of that PPO solicitation, they would be available to any member, not just members who need the most high-intensity care management, but it should be available, to members throughout the spectrum of their care. So if all it is you need to find where to get your kids their immunizations for school, then that care navigation service should be available to help you do that. If it's that you're looking for, a very rare oncologist to treat your unfortunately rare cancer, then they're available for that too. But they should be available to any member that calls.
This is wonderful news. I did not know that part of that. That is, so it could be available to every member.
Yes, the care navigation itself should be available to all members as part of that PPO solicitation. That's what we're looking for. We're looking for that level of service as a part of that solicitation.
And would that be unique, just if we were to do this and it was to happen, would that be unique for our system? Or do others have that?
Others have it. Yeah, I'm not sure how widely it is, but many other, get the terms right, purchasers or health systems are now adopting these care navigation services out of what is a rising need.
Just because we talked to, one of the things that we've been doing as we've been working on the PPO solicitation is we've been having conversations with other large purchasers who run large PPOs, particularly innovative ones. It's a trend that you're starting to see, so
Okay.
it is not, I wouldn't describe it, I don't know, you guys might have a different perspective. I wouldn't describe it as a standard issue or the norm, but it is certainly a direction that thoughtful purchasers are heading in, and some of them have adopted it as well.
Yeah, we're, to Don's point, we've talked to so many other purchasers and done our homework in terms of what's worked for them, what hasn't around population health management. And this is one thing that stands out as something that they're really proud of and really invested in because it does improve outcomes and member experience.
Wonderful. Thank you so much. Appreciate it.
Thank you.
Thank you, Mr. Pacheco. Ms. Walker?
Thank you. I just have two questions. The member advisory committee that how do they get populated?
Great question. So it's basically modeled on what the Department of Healthcare Services has in place for its health plans or requires them to do, but the health plan itself must solicit members for its member advisory committee, and they must do so, like for CalPERS, it must be amongst CalPERS members, and they have to make a concerted effort to ensure that the membership is representative of their health plan members, so it should be diverse, right? And so the health plan are the ones that do it, but it's also important that the health plan ensure that the committee is majority members. So it's not to be a health plan committee that members happen to sit on. It's a member committee that a few health plan members are also invited to in order to help facilitate, ensure that they have all the appropriate resources and that they get the information from the members.
Thank you. Sure. And then my second question, for telehealth, which I think, I don't know, I'm of two minds about it. One, I like it, and then other times I don't. But is there like a limit, like you go through to like 3 telehealth and then you have to have an in-person, or is there any kind of thing like that?
That's an excellent question. And just on your views of telehealth, I also go both ways. I've seen it really work and improve access, and I've also seen it increase utilization over time. So yeah, it's a double-edged sword. But your question about whether or not a member has to go through telehealth first, we are very explicit with our plans that it's a member's choice, and when medically appropriate, that they go to the right level of care. So if they do not like telehealth, if they don't benefit from it, they can request an in-person visit.
That wasn't quite it.
Oh, I'm sorry.
Oh, no,
Okay,
no,
go
that
ahead.
was fine, but that was good to know too. But, so like, going through the telehealth, right? So I'm seeing my doctor, and I've seen her 5 times over the computer, you know? And then, so is there standards of like, if you've seen your provider over the computer 5 times, or whatever times it is, whatever that number is, then is it recommended? Do you have to? Or is telehealth still kind of new that they haven't figured out the ratio?
Okay, yeah, that is another good question. There aren't standards yet about when it is appropriate to come in person for a visit. And that's usually up to the patient and the provider when that time is appropriate. As an example, when I see patients, if I have telehealth visits with them and then they, I look at their list of preventive services that they need doing, like if a patient needs a pap test and they haven't done it in several years and they need to, then I would say, you know what, why don't you come in next time and we can have our visit in person. You need to get this screening, let's just do it, that sort of thing. It's kind of a one-to-one kind of decision, but that's a really excellent thing that you bring up, and something that we're looking at in our RAND telehealth study that David Kelling is going to talk about in the next session.
Thank you, Ms. Middleton. Thank you.
Thank you again, and this has been a very, very good presentation, and I really appreciate it. I've got a few questions on the behavioral health issues that were raised. Clearly, we're seeing an increase in the number of individuals, both adults and adolescents, that are identifying with behavioral health issues. What's your sense of what is driving that increase?
Yeah, excellent question. Yeah, I think it's multifactorial, and it's so different for each individual, especially when you look at adults and children. As I mentioned in the presentation, children, the youth of our time are going through changes and events that just, adults didn't experience, and social media, like the U.S. Surgeon General noted, is really changing how they perceive the world and how they perceive themselves. So I think youth have kind of different inputs that are driving that. I still think that the pandemic was really a pivotal moment in terms of behavioral health for both youth and adults. From all that we've read, there was just sort of like this slow increase in behavioral health issues, and then the pandemic hit, and we just saw that dramatic increase. And those increases, we saw a minor dip, but I don't think, I think we're going to continue to see it. I think also that stigma, there's definitely still stigma, but we're talking about stigma now and what it is, and how to understand, how to identify it, and how to encourage people to seek behavioral health. I've seen it, seeing patients that people talk about their behavioral health needs more than they used to. It used to be something that you had to draw out of people, and now it's sort of front and center that people want to talk about it. So I'm not sure I have, just the right answer, but I think there's so many inputs that are changing our lives.
So when I look at these charts, and it shows anxiety disorder and depression, is there an overlap of those numbers where some individuals actually are reporting that they have both conditions, or is this additive?
That's a good question. I would assume that there probably is a little bit of overlap. The way we looked at the data was if someone had a diagnosis of anxiety or depression. That being said, there are certain codes that include anxiety disorder with depression, or vice versa. So there is probably a bit of overlap with those numbers. And I do also think that many of those numbers may be underreported, because people can present with other issues besides depression and anxiety.
Do we have a sense of what percentage of our members actually are being reported as having behavioral health or mental health issues?
I don't, are you looking for percentages, or are you?
Trying to get a sense, are we talking 5%, 10%, 15% patients that actually are reporting issues?
It's likely about 15 to 20%.
Right. Which, you spoke about telehealth, but it begs the question as to the adequacy of the number of providers of treatment. And I know telehealth has been a help in that, but is there reason to believe, which I hear anecdotally, that the number of specialists available to provide behavioral health treatment is disproportionately less than if we were talking about individuals with cardiac conditions or other types of chronic illnesses that we're all familiar with?
Yeah, and that's something that we have discussed over the years, are workforce issues. And when I think of workforce, I think of the current supply of behavioral health providers, and then I think about the pipeline of providers. And so there are certain things going on to increase the current supply of providers, integration of behavioral health and primary care. The advanced primary care pilot that we're working on is something that we're doing to increase the capacity of current providers. Certainly primary care clinicians are well suited and well trained to at least identify and be able to refer to behavioral health specialists. But you're right, the capacity of the current behavioral health workforce is really strained. We have about 5,400 psychiatrists in the state, many fewer child psychiatrists, and the number of psychiatric residencies has increased by, I think, 2 or 3 over the past several years. So we're just, the continuum of care and who can provide that care is really lacking in our state. Psychiatrists also are about 4% of the behavioral health workforce. So we really need to look at not just psychiatrists, but like I said, primary care providers and non-physicians like therapists and marriage and family therapists and people like that, because they can really serve to create a continuum of care for people struggling with behavioral health.
If I can just add one other thing, which is, so the advanced primary care and the behavioral health integration is also a strategy for increasing workforce. So there's a lot of capacity opportunity there, but primary care providers can be trained to provide care for certain types of behavioral health conditions. It's just something that needs to happen more consistently, and it's part of the reason that we're promoting it.
This is something that we've talked about, and I know we've shown leadership, but this is an area where, to the extent that CalPERS can leverage our position in the marketplace and the number of members that we have to make substantive improvement in the number of providers that are available. I can only speak for myself, but I think this board would stand up and cheer those kinds of efforts. So, last comment I have to make is, as someone who came out 30 years ago as transgender, as a CalPERS member at a time that there was an explicit and absolute prohibition on providing any care related to my condition, it is incredibly affirming to listen to the normalization of that care and treatment that we're seeing today. but none of us can escape what we see happening in the balance of the country, and never has it been more important that we maintain our commitment and that we maintain all of the fact-finding and records and demonstration of the effectiveness of this treatment to our members and to the country. Thank you.
Thank you, Ms. Middleton, for those comments. We are at the end of board commentary. I want to thank our speakers, Dr. Logan, Dr. Albers. Lots of statistics and information. We appreciate it, especially concerning these particular issues. So thank you very much. Before I send everybody to lunch, do we have any public comment? All right, so we're gonna take our lunch break and return here in about an hour, about 1:15. We're a little longer than an hour. So enjoy your lunch, everybody. All right, good, good. So, welcome back. Hope everybody had a good lunch. We're gonna get the afternoon started with a look at our healthcare data and how we can best use it to drive healthcare innovation to meet our members' needs. I think we had a lot of questions on this, so this is very timely for today.
And if it's okay, Ms. Taylor, I was going to introduce.
Yes, you were. Sorry, Don.
Jared,
You told me earlier.
It is okay. Lunch does that to us. So I'm really excited to introduce the next two panelists. Jared Shinneberry joined CalPERS in March of this year, so very recently, as the Chief Health Data Strategy Officer. Jared oversees the Health Research and Information Systems Services section and leads key initiatives to leverage data to drive evidence-based decisions, policies, and programs. Before joining CalPERS, Jared was Vice President of Network Success at Aledade, a population health company, where he led a team that helped independent primary care practices across the country lower costs and improve health outcomes using robust data platform education and ongoing support. Prior to that, Jared was Deputy Secretary of Health Resources and Services and the Chief Business Analytics Officer at the Pennsylvania Department of Health, where he led several statewide initiatives to tackle public health crises, including the opioid epidemic, the COVID-19 pandemic, and led the data modernization initiative to build a better data ecosystem and drive public health policy and programs. Jared holds a master's in public health from Tufts University School of Medicine. So we have been looking for the right person to lead our data strategy, and we were so excited to entice Jared back into public service and welcome him to CalPERS. I also want to introduce David Cowling, who is, I think, new to a lot of the board members, not to all of you. David is a research scientist at CalPERS, where he started in 2012. He leads the research team that assesses and evaluates innovative healthcare strategies. the team has developed and worked on studies to evaluate the effectiveness of price transparency tools, reference pricing, centers of excellence, integrated health management, and more recently, telemedicine. David previously was head of the evaluation for the California Tobacco Control Program, where he led studies on the effectiveness of tobacco control policies, media campaigns, and in-school education campaigns. He holds a PhD in epidemiology and an MS in statistics, both from UC Davis. Before I got to CalPERS, CalPERS has this fantastic national reputation for innovation, almost all of which is based on the published work of David and his team. Really formidable work that they've done in research. It's a tremendous, I think, under-recognized resource at CalPERS. So David's going to talk a little bit about his program. So I'll go ahead and turn it over to Jared, who I think is going first.
Thank you, Don, for the introduction, and good afternoon, President Taylor and members of the board. I'm Jared Chinneberry, CalPERS team member, and I have the distinct pleasure of presenting to you all after lunch when everyone's spry and alert. I'm going to be talking about some exciting work we're doing at CalPERS to advance our health data strategy. And to begin, I'll provide a little bit of background information on sort of the data that we do collect. So our health plans and our pharmacy benefit manager are contractually required to report data to us on a monthly basis. And this is in large part intended to ensure that CalPERS has the detailed health service records behind the invoices that we pay to health plans. So that way we can fulfill our fiduciary duty and hold health plans accountable for costs and the quality of care for our members. So data that we collect include medical claims or encounters detailing the services provided, prescription drug claims, ancillary claims such as medical equipment, lab reports such as blood work, and information on the contracted providers and facilities in our network. We also have data on health plan member enrollment and facilities in our network. Health plan member enrollment as well as the health demographic profile, which provides us with the information we need to better understand health equity and disparities that may be affecting the health outcomes of our members. So CalPERS stores this health data in a secure, centralized repository called a data warehouse. And that's designed to enable and support business intelligence, reporting, and analysis. The data is de-identified before it's made available to CalPERS team members by removing identifiers such as names and addresses. That means even CalPERS team members are unable to access identified health information. CalPERS Data Warehouse was created actually over 2 decades ago in 2002. It's administered by a third party, Milliman, who is responsible for the technical aspects of the data warehouse, including data collection and integration, quality improvement, security, backup, performance monitoring, change management, and providing software interfaces for accessing and analyzing the data. We completed a solicitation recently in 2022 for the 5th generation of the data warehouse, which was awarded to Milliman. And in September 2021, the board approved the contract term of 5 years with up to 5 optional 1-year extensions. The warehouse stores approximately 1 billion medical, pharmaceutical, and lab records, and approximately 90 million new records are collected every year. These data are an extraordinarily valuable asset. Very few purchasers have such a robust data warehouse. And later in my presentation, I will elaborate on how we use the data today and strategies for maximizing how we leverage the data to the benefit of our members. But before we get to that, I did want to talk about security. So the privacy and security of our members' health data is of paramount importance given the sensitivity of the information. That's why we have strong safeguards in place to protect members' privacy rights and prevent unauthorized access to their personal health information. The data warehouse is implemented entirely in a secure Microsoft Azure data center physically located in the United States. Microsoft Azure is a cloud-based solution that is used and trusted by thousands of companies to store sensitive information. In addition, the data warehouse undergoes third-party security audits annually. So in November 2022, Milliman's data warehouse system was issued a Service Organization Control Type 2, or SOC 2, accreditation by Baker Tilly, which is a nationally recognized auditing firm. And the SOC 2 report evaluates the effectiveness of meta-and-site security controls, including availability, integrity, and confidentiality. Milliman is also subject to strict laws regulating the treatment of health data, such as HIPAA and the Health Information Technology for Economic and Clinical Health Act, also known as HITECH, and they regularly undergo third-party assessment of their compliance with HIPAA's privacy, security, breach notification, and enforcement rules. And specifically, the data warehouse is high trust certified, and Milliman is sort of recertified for high trust every 2 years. Milliman also encrypts all non-public data collected during storage and transmission. The encryption methods used are comply with the advanced encryption standards set by NIST, which stands for the National Institute of Standards and Technology. It's an industry standard. In addition, we have strict access control in place for the data warehouse. Access is limited to the data and the reports necessary for CalPERS to conduct our business, and only to staff explicitly authorized for that access. Furthermore, Milliman maintains audit records of any and all access to the system, including what was accessed. And CalPERS team members with access must undergo information security and privacy training annually in order to have access to the data warehouse. And just to reiterate, as I mentioned earlier, the CalPERS team is not able to access identified information, so that data is de-identified by removing the names and addresses, and we assign anonymous unique identifiers to each record. Additionally, CalPERS has strict data sharing protocols that must be followed before we release any data from the system. So if there's any possibility of re-identification, we require data sharing agreements that ensure compliance with HIPAA. So all of these safeguards are reviewed annually, and we just to ensure that they're up to date and in compliance with the latest security standards, so that we can be confident we're doing everything that we can to preserve the privacy and security of the health data. Okay, so now that I've covered sort of what we collect and how we secure it, I'll talk about the why. So the health data we collect are critical for our core operations and programs that ensure that we deliver exceptional healthcare for our members. We use the data for a wide variety of analyses to track performance and help us make smarter business decisions. So examples include tracking and reporting high-level metrics such as the total number of members in each health plan and total dollars spent, calculating key financial indicators such as the % change in allowed per member per month spending over time. Data is also critical for actuarial analyses, to estimate budgets, calculate risk scores for members, and to inform the rate development process and negotiations with health plans. Data helps us identify opportunities to improve outcomes and manage healthcare service utilization through disease or case management. And we need data to compare cost and efficiency of healthcare providers in our networks, as well as to evaluate different options for improving benefit design. Data is used to assess the performance of our health plans and improving the quality of care provided to our members. And we also have targeted research projects studying the impact of benefit design strategies. So on a select basis, we'll partner with academic institutions on projects that we believe will be beneficial to CalPERS members. Though we only share de-identified information with our academic partners, we nonetheless hold them to strict and contractually enforced requirements regarding how they access and use that data. And in just a moment, Dr. Cowling will be talking a little bit more about some of the research that we have done and are planning on doing at CalPERS. Okay, getting to the data strategy. So CalPERS is already quite data-driven as an organization. So question is, why do we need a data strategy? Well, we want to do everything we can for our members, in short. And the more data-driven that we can be in our efforts to fulfill our fiduciary duties as a large purchaser and improve the quality of care for our members, the better. So I was just at a conference last month, actually, and someone said, well, CalPERS is not a large purchaser. CalPERS is a gigantic purchaser. And so, well, as a gigantic purchaser, we also have a gigantic amount of data. And in order to succeed at unlocking the full potential of that data to our advantage and to the advantage of our members, we need a very deliberate strategy with a clear focus. Only few purchasers and employers have really figured out how to effectively collect, store, and manage data from their health plans, and even fewer have figured out how to effectively use it. CalPERS' new data strategy is a result of an environmental scan where we interviewed approximately 35 stakeholders internally and externally to understand existing pain points and areas of opportunity. This includes meeting with other purchasers and purchaser associations to understand their approach to leveraging health data and where they've had success. So the vision and the mission of the health data strategy is closely aligned with the goals outlined in CalPERS' most recent strategic plan. Our vision is to be the industry leader in leveraging healthcare data to accelerate innovation, accountability, and continuous improvement in the delivery of quality, accessible, affordable, and equitable healthcare for our members. Our mission is to unlock the full potential of our healthcare data to drive evidence-based decisions, policies, and programs through accessible, timely, reliable, and actionable data insights. So our vision and mission ensure we're not doing data analysis for the sake of data analysis. This is about starting with what we want to accomplish for our members and working backwards from there to provide the data insights we need to maximize our success. So we have 5 goals stemming from our mission, which set forth what we'll be striving towards in the future. The first goal is data accessibility, or streamlining access to data insights. We hope to accomplish this in part through self-service analytics. And there are 2 ways to get data insights that are critical to CalPERS Health Team's decision-making process. One is to ask someone to analyze the data and produce a report, which can result in a significant lag time before the team has the answers needed. And this doesn't really align well with the agility required for timely data-driven decision-making. The second way is to enable members of the CalPERS Health Team to access the data insights themselves. Self-service analytics enables us to independently explore data and derive insights in near real time, resulting in faster evidence-based decision-making. So I mentioned here a dashboard portal. So it's our goal to sort of shift focus to proactively surfacing data insights by building a curated data dashboard portal. This would be a one-stop shop where CalPERS Health Team could find interactive visual dashboards covering quality, accessibility, affordability, and equity. The dashboard will give CalPERS users the flexibility to apply filters and visualize data that are most relevant to their specific needs. And it will encourage them to actively engage with the data, share insights, and collaborate with one another in exploring and interpreting the data, which will ultimately foster a data-driven culture across CalPERS. And self-service analytics can really only be achieved in the context of a well-designed data management strategy in which thoughtful data governance is applied across all data assets. And when I say data governance, so data governance is like a framework for ensuring the data quality, security, accessibility, and compliance while promoting collaboration and knowledge sharing and consistent interpretation and use of the data. And fortunately, CalPERS already has a well-governed data warehouse with substantial data quality processes and security protocols in place. But data governance can also help us prioritize and refine how we use the data and reassess priorities in light of new use cases and changing business needs on an ongoing basis. All right, there are 4 more goals that we're striving for. The second goal is timely data. So we want to be making decisions based on the most recent data available. We recently moved the data warehouse to a cloud-based platform, which made it quicker to perform refreshes with the latest data information. We'll also be building automations to refresh dashboards as new data comes in instead of relying on manual processes. And goal 3 is reliable data. Because we're using the data to make decisions, we need to make sure it's accurate. So this means ensuring that we have strong and ongoing data improvement processes and discipline and rigor in our analyses. We have a data confidence model that involves pretty extensive data quality checks and frequent interactions with health plans on filling gaps and correcting errors in the data that we receive from them. But there's always room for improvement, and that's just sort of the nature of data quality. Our 4th goal is actionable data. So our data should be easily understood by and meaningful to CalPERS team members. We don't want to analyze data for the sake of analyzing data. As I said earlier, we want to drive an action or a recommendation. So we work backwards from the business goal. To give an example, say we want to do something to reduce pharma spend. So what do we need to do? What do we need to know to do that well? So first, we'll want to understand what's driving high utilization, and which medical conditions we should be paying attention to, and which medications are driving costs, and whether there are biosimilars for those meds, and what portion of our spend is on brand medication when generics are available. So making this information readily available is how we surface opportunities. This is how we design an intervention or a policy that makes sense for CalPERS and our specific issues. Data enrichment would also fall under this goal of having actionable data. So for example, if we enrich our claims data with data on the quality of hospitals and providers, suddenly there's so much more that we can do with that information. And I'll talk more about that in a moment. Our 5th and final goal is industry leadership. As the 2nd largest public purchaser of health benefits in the United States, CalPERS is in the position to establish a strong presence as an industry leader in leveraging health data to drive innovation and shape the future of healthcare. So this is about forming strong collaborative relationships with other purchasers and exchanging ideas, best practices, and lessons learned. This is about contributing to broader initiatives that are shaping healthcare in California or in the United States, like the All-Payer Claims Database and the Data Exchange Framework. And this is about piloting innovative things, perhaps in partnership with associations or academic institutions. I'm confident that these goals will set CalPERS on the path to be one of the most advanced data-driven purchasers of health benefits in the industry, and ultimately to the benefit of our members. But as the saying goes, execution's everything. So I'd like to provide a few tangible examples of what we hope to achieve with the new health data strategy. Okay, so ultimately what we want to do is close that gap between data and action so we can better improve the outcomes for our members. And as I mentioned earlier, the data dashboard portal is an important step in that direction. So as part of that, this year we'll be building a health plan performance and health quality dashboard. And the purpose is to proactively hold health plans accountable for meeting their performance metrics related to quality, behavioral health, and healthcare equity. Health plans are already on the hook for meeting specific quality targets that are outlined in our quality alignment measure set. You heard about that earlier today. This dashboard will help us actively monitor progress towards meeting those targets and to compare measures across health plans and potentially even other purchasers who have the same measures, like Cover California and the Department of Healthcare Services. So we plan to create views to highlight quality disparities across different demographics, which will allow us to pressure health plans to take measures to address them. We also have plans for using data to optimize the quality of our provider networks. So CalPERS does not take health plans' word that they're doing everything they can to ensure our members are getting the best care. To that end, we want to use our data, potentially in combination with third-party data sources, to identify high and low performing providers, facilities, and medical groups. This is especially important in the PPO plans, as they lack the care coordination that is foundational to HMOs. By measuring provider performance and cost efficiency, we will be better armed to optimize our networks over time to ensure our members have access to high quality care at affordable rates. We will use solicitations, contract negotiations, network quality requirements, and periodic business reviews to apply pressure to health plans to maximize member access to those high-performing and low-cost providers. We would also like to leverage case management and disease management services to inform our members about the quality of providers so they can make informed decisions when they're trying to navigate the healthcare system. And we're working on some new strategies for the upcoming PPO RFP to do just that. And I'll wrap up with just one more example of a dashboard that we're working on, the healthcare cost and utilization dashboard. So this will add focus to our cost-cutting efforts through the identification and close monitoring of cost drivers. Some of you may recall that the Healthcare Cost Institute presented to the board a few years ago at the January 2020 Board Education Day. They published an annual report on the cost and utilization trends nationally. So taking inspiration from that, we'll create a CalPERS version that includes a granular view of cost drivers broken out by inpatient, outpatient, professional services, and prescription drug spending trends. These visuals will highlight what we need to focus on and will allow us to easily compare trends across health plans, demographics, and geographic regions. We will also be able to easily see how CalPERS compares to national trends, so we will know where we're doing well and where we have work to do. In conclusion, through our health data strategy, CalPERS is emphasizing our commitment to driving meaningful change through evidence-based policies and programs. Our data strategy also reflects our commitment to monitor the performance of health plans and to hold them accountable for adhering to our quality standards and ensuring that all of our members have access to high-value, affordable, and equitable health care. This concludes my portion of the presentation, and I'll turn it to my esteemed colleague, Dr. Cowling.
Thank you, Jared. Good afternoon, President Taylor and board members. David Cowling, CalPERS team member. As Don stated, I've been at CalPERS doing healthcare research for 11 years, and I oversee a capable team of researchers that conduct a thorough and complex research. As Don mentioned, I have degrees in epidemiology and statistics. Currently and over time, we've had PhD and master levels degree staff with concentrations in things like health services research, economics, nutrition, and public health. As you heard from Jared, CalPERS is an industry leader in healthcare, and part of that is ensuring that the research that we are doing is not only helping ourselves be better purchasers, but also helping other healthcare purchasers. In turn, they can help us. We use a lot of tools at our disposal, including, as Jared just mentioned, the data warehouse for utilization and cost. We also are interested in our members' experience with healthcare, and this includes doing things like web and mail-based surveys, member interviews, focus groups, and analyzing something like the use of a price transparency tool. As I move forward in this presentation, I'm going to give an overview of CalPERS healthcare research, which includes previous, current, and future research projects. You will note that I added the word evaluation to the top of this for healthcare research and evaluation, because a lot of what we do is evaluate our efforts. In the healthcare world, not only is CalPERS an industry leader, but we're also known as an innovator. Our programs are studied by academics, the subject of articles in newspapers, magazines, blogs, and videos are dedicated to the discussion of our efforts. Our goal is to produce high-quality research of our innovative health benefit design strategies to improve the programs and our benefit to our members. In addition to the research we do internally, we selectively partner with academic organizations periodically when we think it'll benefit our members and we can leverage a researcher's area of expertise to provide further insight. Communicating our findings is also important, and we do this by presenting to the board, writing articles for newsletters, presenting at meetings or conferences, and publishing in peer-reviewed journals. And the most important outcome of all of this is making our programs better to improve the quality and cost of our healthcare that we deliver. To give you a sense of the breadth and depth of the research we conduct, I'm going to highlight several impactful and innovative projects that we've done over the past several years. The first one is CalPERS was one of the first large-scale purchasers to offer a price transparency tool in July of 2014, and we felt it was necessary to conduct a thorough evaluation to better understand its value to us and the healthcare marketplace. We partnered with Harvard's on part of this project, in which we conducted interviews, surveys, and healthcare claims analysis amongst users and non-users of the tool. We found that usage of the tool was not high, not sustained, and did not fit very well with our benefit design. The CalPERS PPO benefit design doesn't necessarily encourage shopping for the most part, and that limits some of its effectiveness. However, the price transparency tool was more useful for CalPERS members when used for reference pricing or other sites of care approaches. These results were published over a series of 3 articles and were twice presented to the board. We ended up moving away from this specific price transparency tool, but this research, along with other research, ended up really changing the way in which price transparency tools are thought about and offered today in the healthcare market. The next project is CalPERS was a partner with Blue Shield of California, Hill Physicians Group, and Dignity Health in one of the first commercial accountable care organizations, or ACOs. This commercial ACO was started in Sacramento in 2010. In general, an ACO is a group of healthcare organizations that are responsible for the financial and quality outcomes for a defined population across the continuum of care. This commercial ACO sought to have better coordinated care and health management that would lead to higher quality care and lower costs. There were a variety of strategies to achieve these that include better data exchange, reducing clinical variation, personalizing care and disease management, and reducing pharmacy costs. This ACO is kind of a template for the beginnings of the Blue Shield of California TRIO product. As part of this ACO research evaluation, we looked over a 5-year period at medical and pharmacy quality, utilization, cost, and patient experience. This 5-year evaluation is one of the longest commercial populations studied with any substantial size. We concluded that some quality measures and spending were improved over time, but had a limited impact on some of the other measures, including patient experience. Consequently, the lessons learned here have emphasized the need to include more healthcare quality and pharmacy-related goals to these commercial ACO agreements. Some of you remember I presented these findings at the board in July 2019 at the offsite. Now I'm going to focus on 2 more recent projects. CalPERS in 2019 implemented a value-based insurance design, or what's commonly called VBID, into our PERS Select plan, which is now PERS Gold. In general, the main purpose of VBID plan is to purchase more of the high-value care and less of the low-value care. The stated CalPERS objectives were to provide economic incentives for members to receive high-value coordinated care at the right place and time through a personal primary care physician, or PCP, increase member engagement in healthcare decisions, and reward members for engaging in healthy activities. Also, the goal was to empower freedom of choice, improve outcomes, and lower costs and premiums in the long term. In real terms, this means that if a member has an assigned PCP, they pay $10 for a PCP or specialty visit, or they would pay their regular $35 copay instead. Additionally, members can reduce their inpatient deductible by half through completion of 5 activities. These activities are annual biometric screening, flu shots, non-smoking certification, second opinion for elective surgeries, and disease management participation. We were able to publish these findings from this evaluation in March of this year. What we found was that the VBID program was associated with some of the targeted spending and utilization categories. One of the concerns of a VBID program is that part of the goal is to increase utilization of the high-value services, and that those would increase the total cost of care, especially in the short term. But that is not what we saw here, as there were no added costs over the first 2 years. These findings led to an invited commentary by the JAMA Network Open on the evaluation effort and its findings. We have taken some lessons from our implementation of the VBID program, including re-examining those activities to reduce the inpatient deductible and trying to increase member participation in the current program activities that can improve their health. As an example, just over half our members received a flu shot, and this is an activity that could have a higher participation rate. We are taking the lessons learned here to inform our approach for the upcoming PPO contract and future iterations of VBID. The next project is our most recent project, was to understand the vast explosion of telehealth during the start of the pandemic. And you've heard about some of that earlier today from Julia. We partnered with UC Berkeley, RAND, and the California Healthcare Foundation to explore our experiences, as well as compare our experience to Medi-Cal members. We saw a very large increase in Kaiser's use of telehealth, who already had a relatively higher use of these services. Although we saw high use amongst our other plans, it was of lower magnitude and was not as sustained. Also, as we tried to understand this further and come at this from multiple angles, we conducted patient experience surveys in 2020 and 2021. I will use our experience with telehealth as an example of how we use our data to better understand what's going on and how that can lead to understanding policies. So I have this chart. It's really just an example of a jumping off point of early in the pandemic, we created some charts looking at telehealth utilization. And this motivated some of our collaborative work with UC Berkeley and RAND, which ultimately led to the framing of findings in one of those telehealth papers that I mentioned on the previous slide, that healthcare system characteristics, such as being an integrated healthcare system, are more influential to telehealth use than individual member characteristics, such as like members' age. These findings also led us to want to understand member experience better and understand why members were and were not using telehealth services. So in early 2021, we asked members about their telehealth use in 2020. Even though we asked all of our membership about their telehealth experience, I'm focusing here on this table on our basic membership because we directly have an impact, we have the ability to impact telehealth policies in our basic plans. And one concern with telehealth was that there may be groups of members or services where telehealth may not be as useful, convenient, or appropriate. So here in this slide, we see that members in the 56 to 65 age category are less likely to say telehealth is convenient, their preferred way of receiving care, and that the technology is difficult for me. This suggests that we need to work with our plans to make sure that the telehealth applications are easy to use and that support training for clinicians and support staff such that they can help members increase their access. Also, this suggests to me that when appropriate, that we can encourage and promote the use of phone-only telehealth. This has implications for things like payment parity between the modes of telehealth and what services are most appropriate for this age group. As an example, there's a lot of evidence that, and we heard this earlier, that behavioral health services can be appropriate on the phone, and that this may be a preferable option for this specific group. Next up, I have a slide looking at where members report they would have gone for care instead if they had not used telemedicine. And I think there's several ways to look at this data on this chart. Members report that they could have gone to the doctor's office most of the time, but at about 10% of the time, they would have gone to urgent care, and about 5% of the time, they would have gone to the emergency room. This diversion of care, especially during the COVID pandemic, away from urgent care and the ER, implies that telehealth was a useful option that kept our members out of potentially very crowded and costly sites of care. There's a lot more information that we found about telehealth that changed during COVID, and members have become more comfortable with it over time, especially if they're seeing their PCP or their regular doctors. These insights have informed the virtual care component of the upcoming PPO solicitation and our current HMO contracts. And then now I'm going to move on to our current research projects that are all currently in progress. As you can see, we're still exploring these telehealth services, and we're expanding our telehealth utilization experience studies by trying to better understand telehealth clinical quality. There's very little research in this area, and so we're excited to better understand how prescribing patterns differ, how follow-up services such as labs or radiology are used, or if there is an ER or urgent care visit within, say, 2 to 10 days after a telehealth visit. Again, we've partnered with RAND on this project and hope to have some findings soon. The next project is an internal one where we are working on maternity quality project. There's a larger long-term initiative with Department of Healthcare Services, Covered California, and the California Maternal Quality Care Collaborative to address unnecessary C-sections. And this effort has lowered C-sections statewide from 2015 to 2020. In addition, CalPERS has addressed this issue by including a performance measure in our health plan contracts related to C-sections. Because there are about 10,000 live births every year amongst our members, we are interested in understanding the use of C-section in terms of their geographic distribution, important characteristics associated with them, especially as it relates to disparities. We know in California that large maternal health disparities exist, and we would like to better understand that for our specific population. These results will help us work with our plans to target interventions to specific hospitals or CalPERS members in these groups with disparities. This may also have implications for covering doulas as well. The other current project that we're conducting is a survey of basic members with coordination of care and focusing on members with higher needs and spend. And you heard about this earlier from Lisa, actually, so about this specific initiative. So right now, our PPO products include a limited case and disease management component. However, our HMO products are incentivized to ensure that care is coordinated. Consequently, we're interested in better understanding members' experience with coordinated care. Not only will this provide us a baseline as we introduce this comprehensive population health management component into the new PPO offering, but we should also be able to provide some insight on how that should look. And then last up here, we have 2 future projects listed, and one is a project that we're moving forward with, while the other one is a project that we're exploring. As you know, the board approved member incentive for labs that follows some of the same principles as reference pricing programs within the PPO basic plan that will start in January of 2024. This program is designed to address the large variation in the price of labs, and it should lead to lower costs for our members and CalPERS. Members who go to one of the preferred labs will have no co-insurance, and members that go to the other in-network facilities will pay the usual 10% co-insurance in Platinum and 20% in Gold. We plan on studying this program to understand how it is working and use any of these findings to improve the program. The other project is an evaluation of the biosimilars program that our plans and pharmacy benefit manager are implementing. You may have recently read about biosimilars and what CalPERS is doing about it in the CalPERS newsletter a few weeks ago. Biosimilars have come to the market and have the potential to provide the same level of care at a lower cost to the member and CalPERS. We're exploring the uptake of these biosimilars across our plans, understanding the differences, and identifying what is working and what is not working. This project is in the very beginning stage for my group, although the pharmaceutical team has been following us all along the process. In summary, we've been producing and will continue to produce the highest quality research to evaluate the effectiveness of our health programs. This research can be used to improve the healthcare quality and cost that CalPERS offers to its members. This concludes my presentation, and I'm open to any questions.
Okay, I'll start a list. I've got Mr. Rubalcaba first. Thanks, guys. Excellent presentation, by the way.
Yes, excellent presentation. Thank you, Dr. Ted. President Taylor. I was very, it's great to hear how the data warehouse being used, and both has been used and the programs coming forward. But I had a couple questions about how we could use the data, just given the decision this morning. So I'm assuming one of the regular uses is you track plan enrollment and migration. I'm assuming that's natural. And you also look at utilization. So would you be able to track, given, we moved some plans expanded to new areas where there was only no HMO before, so we want to see how that grows, what impact it has. And the other one is whether there'll be like an incentive for people to stay in network so they don't hit the new out-of-network cap. That would be something that could come out on a report, correct? Is that something that could be tracked?
I'll address the first part of your question, which is, I think Don mentioned it earlier. We worked with a health economist at UC Berkeley to look at, do a very thorough understanding of the way migration of our patterns of our members work. And we, through that process, also worked through expansion into regions of different products, contraction of products over time, to become more familiar with that. And we work with our actuarial office on this as well. And so this is something that we do on an ongoing basis.
Okay, good to know. So I'm looking forward to how we can update the 2024 experience. The other question I had is, I noticed one of the uses is utilization review and analysis. And I remember at one of these offsites, there was a presentation how I think the term is managed competition isn't all that people had promoted it to be, that it's people, that's not what drives premiums, and it's other things. But I think utilization is one of them. I'm not sure if this is well, my question makes sense, but I'm always interested in our members. I mean, there's always variation in our members, not only where they live and demographics, but one of them is family factor. And I haven't really seen anything about what is our family factors and what impact it has in premiums, and is it vary from region to region, or in Southern California to Northern California? Is that an issue why premiums are different? Because I was talking earlier today or yesterday with a couple, Don and some other people. I'm intrigued how rates are relative to others can flip based on the region. And I'm just wondering if family factors anything to do with it, or is it the risk score? I'm just wondering, I don't know. I got excited when you said dashboards, and I remember I used to look at dashboards, but I mean, for smaller plans. I mean, we would look at, the chronic diseases and how they're managed and track it, but I guess we're so big, I hate to ask what they look like, but I'm just excited. You know what? Ignore the question. I'm just very excited. This is working, and we have people here that are looking at it and studying it and continue the innovation. So, you know what, President Taylor, I'm fine. Thank you.
Well, it sounds like what Mr. Rubalcaba is saying is that having all of this information will help us get to better pricing, I think, and I hope. And so we're extremely excited. I think we're all extremely excited about this. Go ahead, Don.
Yeah, I was just going to add, I'm excited for a bunch of different reasons. There we go. Better? Thanks, JJ. So excited for a bunch of different reasons. One is that these are both really small, mighty teams for sure, but also really small. And so we've had a challenge doing one-off data research projects, and there's an overlap in a lot of the key questions, and there's also a sort of forward-looking nature to the data strategy where we're thinking about the things that we really need to focus on, and that's going to be available in a near real-time basis for people without having to make a request. So it programs all of those data insights into everything we do. So it just brings out a lot more in the data. It makes better use of the team. Certainly to your question about the family factor, the regions, other considerations, that's something that we're going to want to look at as we think about the dashboards, and there's always this sort of balance between providing enough to have them be powerful tools and not providing so much so that they bury users. But those are important considerations for CalPERS for sure, because where you live and some of these other factors make a big difference at the end of the day on how much you pay. And there are a lot of insights that come out when we compare some of those aspects as well.
Thank you, Don. I have a list. I've got Yvonne Walker, then JLP, then Gail.
Thank you. I didn't track you when you were talking about the evaluation of the member incentives for labs. So could you go over it again one more time, slow for me?
Sure. This was a program that the board approved recently, and it'll be implemented in January of 2024 in our PPO plans. And so if a member goes to one of these preferred labs, they'll pay zero. There'll be zero cost to the member. Right now, their cost is 10% for for platinum members and 20% for gold members. So if they go to the preferred lab, there'll be zero cost to the members. The reason is that there's a really large pricing variation amongst the price of these labs. And so we really want to get members to these lower cost labs. And
people are going to random labs? I'm not, that's, I guess, where I'm.
so in the PPO product, there's in-network labs, and these have, even within the network, they have huge pricing variation.
Okay.
Like 10 to 20 times the cost between the lowest to the highest cost. And so the idea is to incentivize members to go to these preferred labs, which are at the lower end of the cost. The price variation.
So then I would guess I'd make the assumption that then there's going to be an education component to the members.
Absolutely.
Okay. And then my second thing was, sorry, I was looking to see what I wrote. These microphones, boy. So the telehealth surveys, which I think are great, but is there one that is done simultaneously with the doctors? Because I think there's some cross there of information that we would get, and is it accessible to us?
So two things. One is the plans themselves would do that. For CalPERS, the first iteration of this survey included us working with the plans on targeting members who had had a telehealth visit in the last 6 months, and so we were sure that they had had a telehealth visit. So we did strata that way. But because telehealth became so prominent, we ended up doing more of a random sample, and we ended up getting a large number of people who had had a telehealth visit. So,
no, I don't. That's
yeah,
not what I was asking, though. I don't think so.
Okay.
So, like, you're rightfully, and you have access to, survey our members or however you do it, right? But then, and to kind of get their experience from it. But then on the flip side of that, because they're not the only one with the experience, it's a doctor too. So are they getting that is the health plans, because you don't necessarily have access to that, but are they surveying the doctors to get their experience and then, have a way to line it up, because it might be two totally different things.
Yeah, we did not do that.
Is there a way, I guess not, but is there a way to get it done? Or to think about getting it done?
I would have to think about it, but yeah, I mean, there's surely a way to do it. It's just working through all the logistics.
Yeah, I just worry because, if you're only getting one half of the experience, you're kind
of... Mr. Pacheco, I have you next on the list. Go ahead.
Thank you. Thank you, gentlemen, for your presentation and so forth. I'd like to go back almost to the beginning with respect to the CalPERS data health data as well as the data security privacy system, the whole structure. Now, you mentioned that you started the data warehouse back in 2002. It's in a secure cloud-based architecture, which I believe is the Azure Office 365 environment, and it's nearly 1 billion in records and accumulating about 90 million every year. Is that right?
Yeah, about 1 billion records and 90 million new.
Every year. I say. And then with respect to the data security, I noticed you have the annual third-party security audits and the encrypted at rest and in transit. But with all the data, I mean, from my understanding, with a full cycle data management system, you also should. I don't know if it's incorporated. Maybe it was, but with respect to information retention policies, and I'm just curious if that's incorporated as well, because sometimes when you have data, it just becomes over time it's no longer useful, and it now needs to be departed and released, and even garbage data is sensitive data. So I'm wondering if what sort of policies are in place for that as well.
Yeah, it's a great question. So we retain 10 years worth of data and make that available for analysis purposes. Anything beyond that is just archived and encrypted and not accessed.
So it's archived, encrypted, and it's basically stored within the Office 360 environment, correct?
Correct.
Okay, so and then within that environment, we have certain licensings from Office 365 that we maintain. We maintain those licenses. Am I right?
In this case, it would be our vendor that maintains the license with Microsoft Azure. Yeah.
Azure, and then Milliton is the vendor that manages the data.
Milliman, yes.
Yeah, Milliman. So they're the only ones that have access to the data, or we do? I mean, I'm just trying to understand that connection.
So they kind of have that sort of root access in terms of, as administrators of a data warehouse on the technical aspects of that, right? And then on our side, we have access for analytical purposes. So it's a different layer of access.
Perfect.
Yep.
And then the final question just on this data, because it's just so important. The data is anonymous. No, what do you call it? Anonymized. Anonymized. Yes.
Yep.
So the actual sensitive data of the people's information is released. We only give the information that we need, the actionable information, so that we can generate actionable data for our medical
100%.
Perfect. And that's all I wanted to ask. Thank you.
Thank you.
Okay. Next on the list, Gail, Dr. Willis.
Thank you. Good afternoon, gentlemen. You had specified that the health data strategy that you used was reliable and rigorous in nature. Can you explain and clarify how it was reliable over time, consistent over time? That's my first question, so I'll let you answer that one first.
Yeah, and keep in mind, so the goal of reliability, it's a goal of ours. It's something we're trying to achieve, right? So I'm not saying it's not reliable today. I'm just saying that there's always room for improvement across the board on these. So reliability really comes down to can we trust it? Can we trust it internally? Can we trust it enough to release this to the board and so on, right? And make policy decisions based on this information. And so in order for us to get to that level where we feel like we can fully trust this, we need to make sure that data is accurate. And a lot of that is, there's a variety of different data quality improvement initiatives that we have to do, because data is messy by nature. It's very messy. So there's just a ton of work that needs to go into just maintaining something that's remotely clean and useful for analysis purposes. Mm-hmm. So we spend a lot of time, and so does our vendor, Milliman, spends a lot of time looking at this data and trying to find where there's gaps, where there's issues in quality, where there's inconsistencies, and then we have to go and talk to the health plans on a regular basis, and then we have to force them to try to fix things, and that can be quite a battle sometimes. And so that's really what I mean by reliability.
Okay, and then you said something about the accuracy, which deals with the validity of the data and makes it valid.
Yeah, and so some of that can come into the analysis purpose aspect of it as well. So once we actually get to the point where we feel comfortable with the reliability of the data and we are performing analyses on this, right? how do we know that our analyses are good too? And so there's a lot of internal checks in place as well, where we, you know, in the case of the data strategy, when we're creating something like a data dashboard, where any, you know, people internally at CalPERS can access this and kind of explore that information, it has to be heavily curated, right? Because anything that's on there, we need to make sure it's been thoroughly vetted. Like, this is truth.
Exactly.
As much as we can say it's truth, right?
Absolutely.
And we want that to, we want to create something that we can confidently say is the source of truth, because at some organizations, and it happens to some degree, at CalPERS, it happens to every organization, it's like, who has the source of truth here? You know, this office is saying this thing, this one's saying this thing, they're both looking at the same data, but they have two different results. What's going on? We don't want that, right? We want one source of truth, one place you can go that's central, and you can feel confident that that's accurate.
Thank you. And then also, in terms of the data collection tools, you specified you had interviews, surveys, and focus groups. So how many people were in your focus groups primarily?
So actually, the focus group was ran out of the clinical team, and I'm not exactly sure how many were in the focus group that we conducted. Here, Julia's going to come answer for me.
And then also, how many questions, too? I would like to know the interview.
Yeah, so the focus groups we did were around behavioral health in 2021 and 2022. And we sent out a survey. And then from there, we invited CalPERS members who were interested to participate in a focus group. And there was one focus group per health plan, and there were 8 or 9 members in each of those groups.
That's
Except
excellent.
I think we had 2 focus groups for Kaiser, because they were, as Don mentioned earlier, they about 500,000 of our members, so a huge preponderance of our population.
Yes. And then my final question is, which method of research was used? Was it qualitative, quantitative, or mixed methods? And why was that particular method used?
Yeah, so the focus groups by design were qualitative.
Good, okay.
The surveys are quantitative. The focus groups are qualitative. So typically what we do is we take a survey, we get insights through the survey, and then we follow up on them with the focus group, which gives them a lot more depth, so we understand the responses a lot better when you take 9 people in a room and you spend a few hours with them, kind of going into the gory details about why they feel that way. It's enormously helpful. Yeah, it's enormously helpful.
No, that's great, because it's open-ended, and then the quantitative one is usually closed-ended question, kind of yes/no questions. Okay, thank you very much.
Okay, thank you. Next is Kevin. Go ahead, Mr. Palkey.
Thank you, President Taylor. Thank you, gentlemen. I'm a big fan of big data, and I'm really want to share Director Rubalcava's excitement about the dashboards, or as like we always like to call it, the GUI. But when we are looking at these dashboards so that members can make sound decisions based on their specific situations, looking at the slide on the care, if they showing, what is it, the 70% that they would go to the doctor's office versus the telemed, are we, many times as an end user, you hear the story that it takes them 6 months to see a doctor, and sometimes that's why they'll go to telemed. Are we collecting that type of data as well too, or is that something we would have to work with the providers to bring us?
So, not specifically that question that you asked, but we do ask a number of questions related to access to care, related to did you get timely access to care when you needed it? And that is also acute care, and it can also be, more just regular care as well. So those are things we ask our members through the through our surveys that we do. And in fact, these are performance measures as well that are that we do track. So we definitely saw changes in these measures during COVID. members' access went down in terms of being able to receive that timely care as they needed to before 2020.
Thank you.
So, we are all excited about big data. It's kind of how funny we are with the geeky stuff, but go ahead, Melissa.
Thank you. Again, thank you for the great presentation. I really appreciate hearing all this information. But I'm just curious, from your guys' experience, what information or what data are we missing, or where are the gaps in data that we wish we had that we can't get? Did I stump you? No.
Sorry, we have to conference.
Sure, yeah, for sure. Everyone's.
So one of the items is what Lisa presented earlier. We're still gathering this information on the health demographic profiles and incorporating that into the data warehouse and into a variety of our different pieces of information to help us identify disparities. So I think that's the step that we're doing right now to help fix some of those problems problems in identification, or being able to identify some of these disparities. So I think that's one of the biggest holes that we have in terms of our data.
That's verbatim what I said to him, just to be clear.
Okay. Any other questions from the board? I do have one person that wants to make public comment. Okay. Susan Paradas, you can make public comment. Come on up. 3 minutes.
Suzanne Paradis, California State Retirees. I actually had 2 questions, not a comment. Regarding the survey, page 18 and 19, I saw that it just extends to 56 to 65, and it doesn't go beyond that, and I was wondering about that.
Yeah, so we actually do ask our Medicare members as well about telehealth usage. In this slide here specifically, and I tried to emphasize this when I talked about it, but maybe I didn't do a very good job, which is that on the basic side, we have a lot more ability to pull some policy levers in terms of the way payment parity works or some other things, whereas a lot of the rules are controlled by Medicare and not by us. And so I was just presenting this slide to represent that, if that's what you're getting at.
Okay, yeah. And how was the survey conducted? Was it by phone, by computer, by email?
So we're following the methodologies that NCQA does for their consumer health or patient surveys, which is a mail and web-based survey. So it's a combination of those two. You get it in the mail, you can scan a QR code to get or you can type in the URL to get the web version as well. Okay. And about half of our members do the web and half of them do the mail.
Okay, thank you.
Our next public commenter is Rosemary Knox.
Good afternoon. Very interesting presentation. The thing that was lacking to me was educational component to your members and their being an advocate for their own health care. What have you initiated or placed in an educational component that would help a person understand how to be their own advocate?
Yeah, so I do think that there is potential for using the data we have for that purpose to help inform members. And I did mention one potential use case for doing that, which is when it comes to helping members navigate healthcare, right? Now, we wouldn't be doing that necessarily directly, but by working through a health plan or like a population health management vendor, we can, and sort of in combination with our data, or armed with our data, they can help inform members, say, hey, we saw that you're gonna have, or that you were referred to this provider for knee surgery. There might be better options, better quality of care. and to inform the member so that they can make that decision.
I'm still lacking when you say navigating. To me,
Yeah.
navigating is navigating through a healthcare system. It's not navigating and understanding what the chronic illness is. Obesity, yes, you talk about obesity. How do you educate your members to be able to understand what is best for them?
Yeah. Okay. Thank you for clarifying. Sure, I'll go first and then. At least from my perspective as the data guy, I think that the data can sort of surface to us where we should focus our educational efforts when there needs to be educational efforts. So as an example, if we see a trend with that diabetes is increasing dramatically, year over year, we might say, oh, we need to do something about that. And maybe that involves an educational initiative.
In terms of how we do that, we do it a couple of different ways. One is through our newsletter. So we'll highlight areas of concern, many of which come out of our surveys or our data analysis. We also build it into our contracts with our health plans. So we require that our health plans do a certain level of member education, and we use both the surveys and our data analytics to identify what those areas are. So we will get the kind of data insights that Jared is talking about that we'll be achieving more frequently and in more real time with these dashboards. We will be using those when we contract with health plans and when we work through with our health plans the education campaigns that they provide as well directly to their members.
All right, thank you guys for those answers. It looks like we're done with public comment and board questions. So we will proceed to the next session, which is Enterprise Performance Management. I've got Sabrina Hutchins, Laura Carruthers, and Michelle Tucker for that. Thank you, guys. I want coffee. So, I don't know who's running the session. Michelle, are you?
I'll start, kick it off.
Sabrina's running it? Okay, Sabrina, you go ahead, take it away.
All right, thank you, Madam President. And good afternoon, board members. My name is Sabrina Hutchins, and I'm the Chief of the Enterprise Strategy and Performance Division. Oh, let me get that. Okay.
Let's be nice now.
All right, all right. Okay. And I'm joined by my colleagues, Laura Carruthers, who is our Assistant Division Chief within
Everyone
ESPD,
quiet down, it's hard to hear.
and our HR Director, Michelle Tucker. We're happy to be here with you today to highlight the good work going on at CalPERS from an overarching enterprise view. Next slide. So our goal for today's session is to provide some education to our board members, as we usually provide an enterprise strategy and performance session during July. And we understand many of our board members are new, so we want to utilize this opportunity to provide this foundational insight around our strategic and operational framework as it relates to measurements, as well as highlight some of the initiatives happening throughout the organization. We do maintain a significant amount of data to demonstrate and monitor our progress, and we want to reinforce how this supports your oversight role as the Board of Administration and how this reporting process works for you. Next slide. So as we kick off, I always like to start with our foundation, as it's a reminder and a reinforcement of why we are all here, and that all components of what we will be discussing today are in alignment with our purpose, who we are and what we want to achieve. As a team, we're inspired by our vision and mission to serve those who serve California by delivering retirement and health care benefits to our members and their beneficiaries. In our day-to-day work, we are guided by our core values. Next slide. So starting things out with a little bit of history, about 7 years ago, when Marcy first came on board, she shared her vision with us about the importance of measuring organizational performance and ensuring the effectiveness of our processes. And with that inspiration, we established what we call the Enterprise Performance Management System. And though I refer to this as a system, it is not a technology platform, but a formalized framework of people and processes that helps us maintain the integrity of the goals and expectations we set. The intent of this system is to reinforce CalPERS' desire to be accountable in support of our goals and operational expectations, and to also support the board's oversight role into our strategic priorities, as well as our overarching operations. This involves the development, implementation, monitoring, and reporting of performance metrics that measure our progress on a quarterly basis. Each of our executives own several indicators that represents our team's efforts from throughout the organization. And this gives us a comprehensive view of our progress. This also provides visibility for our stakeholders as they care about what we are doing in our day-to-day business. And also, they want to see strategies and insight into those strategies we've set forth. So on the strategy side of the house within the EPM system, we have our strategic measures and business plan initiatives, which monitor our progress towards meeting our strategic goals and managing our project work. On the operational side of the house, we have our key performance indicators, providing insight to our performance relating to delivering value to our customers. Today, CalPERS is reporting on 52 strategic measures, 49 key performance indicators, and over 30 business plan initiatives within this current fiscal year. And we're going to be highlighting some of these items in our session today. Next slide. So I want to describe the backdrop for each side of the system as I'm talking about strategy and operations. First, we want to reinforce that CalPERS does operate and sponsor a very comprehensive strategic planning framework, and this visual highlights those layers within the framework. Our vision and mission, of course, provides insight to our aspirations and clearly states our purpose for existence, which has not changed with the refresh of our current and new strategic plan. Our goals communicate what we want to accomplish over the long term, and our objectives clarify how we will achieve these stated goals. Our measures provide meaningful progress indicators. So these top 4 layers typically stay consistent over the life of our plan, and we maintain a 5-year plan cycle. We work with the board on this area of the framework through our strategic planning process, and we concluded these efforts back in spring of 2022 to implement our current strategic plan and the measures that are in place today. The bottom layer of this framework is related to our business plan initiatives, and those are determined by our internal team across the organization. This helps us articulate the work or the projects that we're going to undertake to help us achieve our goals along the way. Our business plan does refresh each fiscal year to adapt to our changing business environment and to help us mitigate any barriers to stay in pursuit of our mission and our vision. We kick off the refreshed business plan each fiscal year in July, and as part of your materials for this session, you do have a draft of that plan as we're still finalizing some of these initiatives and the deliverables that are aligned to each initiative. You will see within the presentation today high-level titles referenced within the PowerPoint. We don't plan to review each of those initiatives. Like I said, there's over 30. However, we are happy to answer any questions as we move along. Next slide. So continuing for the strategic side of the house, everything we measure is aligned back to our goals. We just completed the first year of our current strategic plan that's in place for 2022 through 2027. Just a brief review of those goals, starting with our member experience, which is at the heart of everything we do. And our focus is on ensuring that our members receive timely and accurate benefits, as well as improving our service capabilities along the way. Critical to our existence are the efforts related to strengthening the long-term sustainability of the pension fund. And then we have our exceptional healthcare goal that's focused on ensuring our members have access to equitable, high quality, and affordable healthcare. Of course, stakeholder engagement is very important to us, and our goal is to promote collaboration, support, and transparency. And the organizational excellence goal is more internally facing. This goal overall covers processes to improve and create efficiencies, maintain a risk-intelligent culture, enhance our talent management strategies, employee engagement, leadership competencies, as well as promoting and embracing diversity, equity, and inclusion. So for the rest of our session today, we're going to focus in on member experience and the organizational excellence goal, being you've had very informative sessions related to pension sustainability through our investment discussions yesterday, as well as our health programs today. And then tomorrow we know you have a session focused on stakeholder engagement. Next slide. So on the operational side of the house, similar to our strategic goals, we have our operational outcomes that we want to achieve. These expectations were also introduced by Marcy when she first came on board, and these are the processes that we need to be really good at to bring customer value at the operational level. Each of these focused desired outcomes have key performance indicators aligned to them that we do report on quarterly. And when we first introduced this model 7 years ago, we facilitated working sessions with all of our program areas and aligned their core processes to each of these stated outcomes. Each area made recommendations for what would be measured, establishing targets and thresholds that communicate the status of either on target, at risk, or off target. In summary, these outcomes focused on being a reliable steward of the fund, ensuring responsible investments and daily management of our CalPERS assets, and safeguarding the solvency of the fund through sound actuarial practices. We, of course, want to be a customer satisfaction-driven organization, understanding the needs and expectations of our customers, looking for process improvements, innovation opportunities in the benefit of our customers. Being an open and transparent communicator is focused on building working relationships with the board, our team, stakeholders, and outside organizations. Being open and accessible, and working for a solution in a collaborative way, ensuring everyone's voice is heard. Being efficient and effective as an organization, striving for excellence and setting a clear vision for the future, supporting and maintaining high levels of accountability, and hiring and empowering talented teams. And lastly, team member engagement, creating a destination workplace where every team member can thrive and feel proud to work at CalPERS, fostering an inclusive environment where team members are valued and supported for their ideas. Next slide. So in support of these outcomes and strategic goals I just shared, having key data insights to support and inform our decisions is clearly a high priority here at CalPERS. As I just explained with the EPM system, performance metrics and a formal reporting mechanism has been established, which was a significant effort throughout the organization, and we continue to mature in developing and reporting on metrics to demonstrate our performance and maintain accountability in a transparent framework. Prior to 2017, I'll mention our trailblazers in reporting metrics from a data-driven output focus, mainly our customer services area and the investment office. So when we implemented the EPM system back in 2017, this was a culture shift for the organization. And our development process included, again, all of our program areas gaining their input to ensure the long-term success of the program. We also wanted to make sure our teams understood that sharing key data points about progress and performance reflects a healthy organization. And having items either off target or at risk is not meant to get people in trouble, but to shine attention on something to determine if additional help is needed or other resources are needed to ensure the success of these programs or specific projects. So when we do have indicators in the red or yellow indicating at risk or off target, program areas have an opportunity to explain the root causes and communicate their mitigation strategies to getting things back on track. Having measures aligned to our strategic plan was also a significant shift in the organization, as data-driven measures aligned to each goal was first implemented with the 2017 through 2022 strategic plan. As part of that process, we reviewed all of the measures and thresholds with the board, gathered feedback, and finalized each of those measures through the strategic planning process. Each year, we do review our metrics and refine or add items where needed to ensure the relevance of what we are monitoring and reporting on. So all the indicators within our EPM system are reported to the board on a quarterly basis through the Insight tool that our board members utilize for access to committee materials and the TREC system for travel activities. We understand this is a newer tool for many of you, and so many of you are also still using the Diligent application for board materials. And what we plan to do today is be here at the end of after Michelle Nix's session next. We're going to be here to provide any one-on-one navigation support to help you access the Insight tool and see these data elements live within that system. We also understand that additional trainings being coordinated through the board services team for you in the coming months related to using the Insight tool overall. So these EPM reports are also viewable externally on the CalPERS website for our members and stakeholders to view. In addition to the EPM system, we also wanted to highlight our internal efforts related to enterprise performance activities. In 2019, we introduced an additional element of reporting because a lot of the EPM indicators have refresh frequencies that track trends over longer periods of time. And some of these indicators need to be looked at more frequently than our quarterly reporting cycle. We wanted a mechanism and a view in place for more of the critical day-to-day operational activities that we need to keep a close eye on. As part of this process, we established what we call an executive dashboard for reporting key metrics. And these metrics are more internally facing, representing a variety of areas across the organization. This helps keep our executive team updated weekly on items that may have more volatility and provide insight on potential emerging issues. Because this process was implemented just before the pandemic, we were proactively prepared to report these new data points related to how the COVID environment was impacting our business processes, as well as additional team-level insights. These indicators position the organization to make data-driven decisions and proactively address changes in our environment. Examples include items related to the member experience, such as contact center activity, how processes are going related to paying benefits to our members, specifically related to accuracy and the timeliness of benefit payments. And also examples related to our workforce include the hybrid work environment in general, COVID exposures, and vacancy rates. In addition to the executive dashboard indicators, over this past fiscal year, we took another step to maturing our ability to understand our performance and ensuring accountability and transparency, as well as quality outcomes, that those are a priority at the team level in a consistent way. We began the development of KPI workload metrics for all teams across the organization, and Laura is going to be providing more details on this particular initiative in just a few minutes. Again, just reinforcing our priority to be a data-driven organization. This is an ongoing, continuous improvement effort, and having these management tools in place for external and internal visibility supports that intent. Next slide. So we just shared a comprehensive view of various levels of metrics we have at CalPERS. I want to focus us back on the EPM metrics and initiatives for the remainder of the presentation. Before I continue on, I know that was a lot of information just kind of on our foundation and the background. I wanted to pause for any questions or comments so far.
Any board members that want to comment? Oh, okay. I'm sorry, Jose Luis.
That's okay. Just let me, bear with me with my, sorry. We gotta bring these so close now.
I know, it's an awkward microphone.
It is quite, no, it's okay. Anyway, I wanted to go back on, I know you mentioned you cannot, the 30 initiatives and so forth. I just want to know by category, within the 30 business initiatives that are in play for this current year, what are, of the ones that are in it, which ones are associated with IT? Do you know?
We have several related to the IT area so that would be aligned in our organizational excellence goal.
Mm-hmm.
And we did provide the draft of that particular, the business plan in your materials, so we could summarize those.
Just a number or whatever. I mean, of the 30, is it 10 or is it 5 or?
I want to say 2 or 3.
Okay.
Okay, we're going to look real quick.
So there's a couple of them,
yes,
but
thank
most of them we have IT involvement weaved into most of those outputs that we produce for other BPIs as well.
Oh, I see.
So it's all intertwined. Yeah.
It's all intertwined. That's all. That's what I was just wanting to understand.
There's 4.
There's 4. All right. Very good then.
Thank you.
Thank you so much of the 30. All right. Very good then. That's all I was just curious about that. Thank you.
Anybody else? All right, go ahead.
Thank you. Okay, so going back to our strategic plan, next slide. I wanted to also call attention to the deliberate alignment of DE&I priorities throughout the strategic plan, as this demonstrates CalPERS' commitment at the highest level and sets the tone from the top. We have multiple measures and initiatives connected within our pension sustainability, healthcare, and organizational goals. During the first year of the plan, many of these measures were under development in order to establish baselines, and we anticipate learning new insights from the data that we've been able to collect over the life of the plan. And you heard some of this information alluded to in the health session, as well as in yesterday's session. Next slide. And this view summarizes the measures related to each one of those DE&I pillars. I know many of you are already familiar with. Marlene shared these pillars at recent board meetings and shared the collective work that's happening throughout the organization. Next slide. So shifting our focus now to the member experience goal. And before I jump in here, I do want to review the layout of this slide, as you're going to see this format as we continue to introduce segments of metrics and initiatives that we want to highlight. So from left to right, on the left top area, you have the strategic plan objectives, and these are aligned to each one of our goals. Below that is a list of all of our strategic measures and business plan initiatives. Again, these are those high-level titles, and we don't plan to review each one due to our time frame. But again, you do have access to all of these particular items within the Insight tool. And then on the right-hand side, as I mentioned, the operational connection. These are the corresponding operational outcome measures, as well as key performance indicators specifically related to member experience. Next slide. So here's our first example of strategic measure data points related to customer inquiry timeliness as well as satisfaction. As I've made mention within your insight tool, this would be the view that you would see for trends over time. This highlights the targets and the actual status indicators. In this first example, measuring the timeliness of our responses to customer inquiries reflects our commitment to serving our members and employers. While the contact center does close more than 90% of their inquiries at the first point of contact, these data points specifically are related to those more complex inquiries needing more specific business knowledge to resolve. And our team has maintained a status above the target consistently over time. In this second example, to ensure we're listening to our customers and taking action on their feedback, we collect customer satisfaction surveys for many of our business processes. This measures the overall customer satisfaction rate with CalPERS' ability to perform its most core functions of providing and administering retirement benefits. You can see here that the team has continued to maintain status in the green above the target, and we do appreciate those outstanding efforts from our customer services and support area to maintain this level of service. So with that, I'm going to turn it over to Laura.
Thank you, Sabrina. I think JJ can hear me. I'm kind of the loud talker of the group. So thank you, board members, for your time today. Over the next few slides, both myself and Michelle Tucker will review the objectives of the Organizational Excellence Goal and their associated measures and initiatives. I will be highlighting both strategic and operational areas of interest. Organizational excellence is our largest goal in terms of the number of measures and initiatives. And this is because we need to maintain a high-performing workforce and systems to ensure we are able to best serve our members and achieve our mission and vision. I will start with the objective of improving processes and operations and advancing technologies. This objective has 6 measures and 8 BPIs. Also listed are the corresponding operational KPIs that reflect the day-to-day work we do in relation to maintaining our organization. There are 2 operational outcome measures and 5 KPIs that reflect that core workload. Multiple areas work cross-collaboratively to contribute to this goal, and within this objective, those areas include the Policy Research and Data Analytics Division, IT, and the Financial Office. Overall, this goal is about being efficient and effective. For example, the operational efficiencies measure ensures effectiveness of resource allocation for projects so that we are realizing cost savings. As a new measure, we just established a baseline and expect to see progress over the life of the 5-year strategic plan. Now, as Sabrina mentioned, there are way too many items to go into detail on everything. So for this particular objective, I would like to concentrate on an initiative that has been completed this past fiscal year to highlight how we have supported both the measures of operational efficiencies and enterprise operational effectiveness. You can view detailed information about all of the measures, initiatives, and KPIs individually through your Insight tool. So Sabrina showed you an example of how we see data for a measure, and in this slide, I'm going to give you an example of an initiative. BPIs are different from measures as they essentially detail the project work that is being done and why it is needed. So first, let me give you some background on my example, which is the Workload Metrics KPI initiative. The need for the development of internal KPIs in the form of workload metrics was a gap identified as we moved into our hybrid work environment. Whether we work from home or in the office, the need for these KPIs was clear. Therefore, ESPD was tasked with a project to help the organization in the development and reporting of these new workload metric KPIs. Since this was an enterprise priority, it was established as a BPI. All divisions were part of the effort to develop methodologies and subsequent metrics that sufficiently demonstrated that full-time work was being assigned and completed and performed in a way that ensured quality outputs, timely results, and outstanding service. So let me take you through the work we did on this initiative, starting with the why. Why is it important to have workload metric KPIs? First, it helps further ensure our accountability and transparency and enables us to demonstrate those high-quality outcomes. It also improves resource planning and workload allocation, which in turn enables us to have a flexible and agile workforce to meet the evolving needs of our members and our organization. So what did we do? Once the need for metrics across the organization was identified, we knew we needed to make the development and transition to this new process as smooth as possible. So we established a review and reporting process for all of the divisions within the organization, and then each team developed and implemented program-specific metrics. To aid in this effort, we facilitated education sessions, hosted a webinar, developed a SharePoint site with tools and resources, and employed change management strategies where appropriate. ESPD facilitated review and feedback sessions with the executive team, capturing feedback and providing summaries so that all leaders could view the information to aid in their own area's workload metric KPI development. As the areas were developing their metrics, there were specific questions or considerations they needed to answer. How do you demonstrate that full-time work was assigned and completed and that the quality of work is meeting expectations? Now, this was not meant to be a time reporting system. However, some areas with less mature metrics did have to do some informal studies to better understand how long tasks take to ensure that they could demonstrate the answers to those questions. Next steps for us, while we have completed the initial process of developing internal workload metric KPIs, there is more to be done to mature and refine these KPIs. To help inform our next steps, we surveyed leadership across the organization to better understand how the data is being utilized, what the challenges are, and the lessons learned. Some challenges include level of manual work required to complete the reports and how to best ensure accurate data is being captured. Things that people have learned can include better ability to allocate resources and an improved understanding of how long tasks actually take. Using this survey data in combination with the feedback from our executive team during the review process, we summarized our findings and provided recommendations to our executive team. Through those recommendations, this work is going to continue in a new initiative this coming fiscal year. The EPR Enhancements Initiative will make improvements to the internal EPM reporting process. The goal is to further increase accountability, collaboration, and understanding of resources and challenges. As part of this, we will also be establishing an internal senior leader quarterly reporting forum beginning this fiscal year. Through this, we hope to enhance the timeliness, accuracy, and usefulness of information provided to the organization, so we can continue to build on our successes and make course corrections as needed. So now that I've talked about the what and the why, I'd like to show you the how through some examples of metrics within our organization. So this slide has an example of project-based work and how this program area demonstrates full-time work is completed and assigned. This is just a sample using simulated data, but what we see here is a dashboard view which is used in combination with other reporting mechanisms to provide a full picture. Some of the data points captured here include types of projects by business line, number of projects being worked on in the month, number of projects completed for the year, number of projects in the queue, and how hours spent on those tasks within the projects. So this is just one possible version of sharing workload metrics KPI data. Each branch, division, and program area has work that is unique. So there's no one process or system that will work across the board for all areas in CalPERS. And for this reason, we did not prescribe any particular technology or process. Many areas do use Excel, and those with the knowledge and expertise can turn that data into dashboards using Power BI. As Sabrina mentioned, some areas like the customer services and support branch already have more mature metrics, and they're able to gather data from existing systems such as CalPERS. We did try to make the process more organic so that individual teams were able to develop their workload metric KPIs in a way that they felt best displayed the data to answer those questions of full-time work being assigned and completed with quality outputs. Through the stages of development, team members had different levels of engagement. The goal was to involve our team members in the development process, because who better than the people that do the work to assist in determining how to measure performance. In this example, the work is more task-based, demonstrating a mix of project and repetitive cyclical work. The data here is broken out by workload category and has roll-ups at the section, division, and branch levels. It shows the percentage of work each category produces towards the total amount of workload completed. In both of these examples, quality controls are demonstrated through one-on-ones with their leaders, peer review, leadership review, and satisfaction surveys. How often the data is reviewed and utilized varies based on many factors. Team leaders can use this as a day-to-day workload management tool. Based on needs, division chiefs and executives may utilize the information on a monthly, quarterly, or annual basis. This data has also been helpful in resource allocation and providing determinations and justifications for backfilling positions. These are just two types of workload metric KPIs that have been developed in the past year. There are many more that reflect the unique and diverse work we do at CalPERS, and we expect that these metrics will continue to grow and evolve as the priorities of our organization shift to meet the needs of our members. I'm going to pause here. Are there any questions on this particular business plan initiative before I go on to our next topic? Oh, okay. So moving on to another objective within this goal, the objective to cultivate compliance and risk functions throughout the enterprise has 3 measures and 2 BPIs. The corresponding outcome measure has 8 KPIs. You may note that there are several of these measures, BPIs and KPIs, that are italicized with an asterisk. This is because they are reported in closed session due to containing sensitive and confidential information. As with most of our objectives in this goal, multiple areas contribute to get the work done. In this instance, the main contributors are IT, information security, and enterprise compliance. To achieve this objective, we plan to leverage technology and processes to effectively identify, report, and mitigate potential risks to CalPERS and maintain compliance. So you've now seen an example of a measure and a BPI, so I would like to highlight an operational KPI to show you how we measure our day-to-day work of ensuring compliance in 2 key areas. These are 2 KPI trend charts that are examples of our timely completion of Form 700 and our mandated training compliance. These 2 areas are tracked to ensure compliance with all laws, regulations, and rules. And this supports accountability and transparency with our team, our members, and our stakeholders. At the beginning of any type of measure, we set a baseline which helps us to determine our target and thresholds going forward. As you can see, the Form 700 chart, our target is of course to be at 100. However, our threshold is 90 to 100, and this is because we need to give ourselves the flexibility to include factors that are out of our control, like team members being out on extended leave that are not able to complete the forms on time. As long as we are meeting or exceeding this threshold, we are still considered on target. The mandatory training compliance has 6 types of mandatory training that are monitored. These include workplace violence prevention, harassment prevention for employees, harassment prevention for supervisors, mandatory state officials, ethics training course for Form 700 filers, Health Insurance Portability Accountability Act, and information security awareness. To come up with the status score for the completion rates of each of these trainings is weighted and calculated into an average. As an organization, we take ensuring compliance in both of these areas very seriously, setting up mechanisms such as an automated reminder emails and distributing completion reports to divisions to aid in getting these completed on time. Having these trend charts that show our progress over time helps us to understand where we are doing well and where we need to take corrective action. And a trend chart is really just one piece of an overall summary of an individual KPI that contains more details on what we are measuring and why. These charts are an excellent quick visual to see how a measure or a KPI is performing. And for more detail on any KPI, you can read through the entire summary sheet, which you can find in your Insight tool. So again, I'm going to pause here, see if there's any questions before I close out my portion. No? All right, so with that, I'd like to thank you for your time and attention and hand over the presentation to Michelle Tucker to go over the rest of the objectives of this goal. Thank you.
Thank you, Lara. Can you hear me okay? All right. Good afternoon, CalPERS board members. Michelle Tucker, CalPERS team member, Human Resources Division. I'm very excited to share more about our organizational excellence goals today with highlights on a specific rapid recruitment project. HR developed a new mission statement this spring, which supports the CalPERS mission. Foster an engaged and inclusive workplace where each person has the opportunity to grow and thrive. We offer HR guidance on your journey. To succeed in this, HR has responsibility for several strategic measures and business plan initiatives under the organizational excellence goal. Our work on these measures is intended to both improve the team member experience and create operational efficiencies. Next slide. These top-line demographic data points come from the 21-22 DEI Workforce Demographic Review, which is completed for the DEI Annual Report and illustrates some aspects of our workforce. You'll see that we have team members representing 18 different race and ethnicity groups, 5 generations from traditionalists through Gen Z, and 26 languages spoken. This data comes from various CalHR and SEO sources. This diversity of background, thought, and perspective creates a rich mixture of ideas and innovation needed to sustain the fund and improve the system for our members. The center table includes a gender breakdown by broad job groups. While our gender mix is weighted towards females overall, you'll note the senior and executive leadership levels from the 21-22 year were weighted towards males. We're analyzing these trends in our career path analysis project among other markers of success and opportunity across the workforce. We believe the Pathways for Women Conference is one way to bridge this gap. We're thrilled that annual attendees will include some of our own CalPERS team members who will get to share space and stories with exceptional leaders who are living examples of representation. We're in the preliminary stages of analyzing the fiscal year 22-23 demographic numbers to determine what shifts or changes have occurred in our workforce over the last year. I know you're interested in how we are progressing in this front, and I have some exciting stats to share as we dive into our rapid recruitment event presentation. Next slide, please. I'm pleased to share that we continue to implement strategies to influence team member engagement and utilize the Enterprise Engagement Survey Action Planning process for team leaders across the enterprise to engage with their teams. The talent management strategies initiatives are underway and rolling into year 2. The career path analysis project I mentioned on the last slide has identified several areas of opportunity for leadership development and support. This project is looking at areas in the organization that are successfully preparing internal candidates for future roles at CalPERS and contributing to overall retention. A cross-functional team has been working on this and is in the process of analyzing the data they found. One data marker we're very proud of is our Emerging Leader program, where we're pleased to have a 52% internal promotion rate. Our DEI outreach strategy continues to take shape with the addition of our DEI recruiter, who was appointed through our HR Rapid Recruitment event that we'll talk about in a moment. We'll have more for you on these strategies and initiatives as they progress. Next slide. As you heard in CEO Marcy Frost's report at your last board meeting, the rapid recruitment events were born out of a need to address ongoing recruitment challenges and to fill vacancies quickly, with qualified candidates chosen from diverse candidate pools. CalPERS, like many other state departments and the rest of the labor pool, were experiencing new recruitment challenges, and we recognized the need to do something different to address those challenges. The challenges spanned multiple occupational groups and business areas, and we piloted the project within HR first to build and test innovations before training others and conducting a rapid recruitment event, or RRE, which actually isn't that much easier to say, across the enterprise. Various teams worked together to streamline the minimum qualification review and scoring processes and incorporated some proven cohort recruitment and hiring techniques. Some of the methods we used were from other agencies or based on our experiences, and some were already used to some extent within CXD in the CSS program. To illustrate the success of this approach and to share what we expect to see when the enterprise rapid recruitment is complete, I'd like to share the results of the rapid recruitment event on HR's vacancy levels. At the onset of the rapid recruitment event in January 2023, HR's vacancy rate was 19%. We filled 14 analyst positions through this process, and now, as of July 7th, we have a vacancy rate at just 7%, which has reduced significantly from the 19% when we started. After conducting rapid recruitment events across the enterprise, we'll be able to share more about that and the effects on our overall vacancy levels. We did make a total of 167 hires across the enterprise. As of July 12th, 109 of those hires were completed and had either started or had a start date assigned, and the remaining 58 hires are nearing the completion and setting the start date. And again, we'll have more information to share on those appointments as they're processed. Next slide, please. Next, I'll share highlights on how we prepared for the rapid recruitment events. Several CalPERS divisions, including HR, the Policy, Research, and Data Analytics Division, the Office of Public Affairs, and the Operations Support Services Division, partnered together and used existing resources, adopted tools and technologies, designed efficiencies, identified outreach efforts, and prepared for an on-site component for the rapid recruitment event. We had an in-person day on May 12th. We considered things such as the merit system, rules and principles, internal controls needed to maintain confidentiality over the process, and how to best advertise this unique approach to recruiting at CalPERS. We wanted a very broad outreach to increase the applicant pool size and breadth of diversity to support our diversity initiatives. Next slide. We did many things to ensure a diverse pool of candidates and to support an equitable and inclusive hiring process. Some of those elements included use of the on-gig augmented writing software to test and reduce biased language in duty statements, job bulletins, and interview questions. Minimizing biased language increases the likelihood of a diverse applicant pool. We'll begin incorporating the use of this software into all recruitments as we implement lessons learned and other operational improvements from the rapid recruitment events. HR partnered with other CalPERS teams, including the Diversity, Equity, and Inclusion Office, the CalPERS Diversity Outreach Program, and the Equal Employment Opportunity Office to create interview panelist training that included an anti-bias course tailored for recruiting and interviewing. All 296 CalPERS team members participating in interview panels were trained on the rapid recruitment event process, panel interview best practices, and uncovering unconscious bias in recruiting and interviewing. So I know your question is, with all of that, how do we know that progress is being made? How are we moving the needle? Success in our efforts is demonstrated in part by the HR Rapid Recruitment event when we look at the demographic breakdown based on gender and ethnicity. Again, this is a small sample size, but I think its results are very promising. As I mentioned, HR welcomed 14 new team members to the Rapid Recruitment event. As of July 14th, demographic data had been released through the CalHR and SEO systems for 13 of the 14 hires. So a few early observations of the applicants, hires, and current workforce with respect to gender and or race and ethnicity data. The HR Rapid Recruitment event pool of over 600 people was made up of 66.3% females, 31.5% males, and 2.2% unknown. I would like to comment on the unknown. Currently, the state application process has options for males and females, and then when an individual chooses not to select a choice, it goes into unknown. I know there are efforts to update this form, but this is the kind of the current state. The 14 HR hires that are made up of 76.9% females and 23.1% males. We're actually very pleased about the 23.1% males because that exceeds our current composition of 16.1% males. HR is traditionally a female-dominated field, both within public and private industry sectors. This is very promising to provide greater gender balance and diversity. When comparing the demographics of the HR Rapid Recruitment hires to CalPERS, both as a HR division and for the overall CalPERS workforce, we see a higher percentage of diversity. HR Rapid Recruitment hires had a representation of 76.9% historically underrepresented groups, which includes Asian, Black or African American, American Indian or Alaskan Native, Hispanic or Latino, Pacific Islander, and multiple race. So again, that was 76.9% for that group and 23.1% white. In comparison, CalPERS has representation of 43% white and a representation of 57% for the historically underrepresented groups that I just mentioned, which again were Asian, Black or African American, Native American or Alaskan Native, Hispanic or Latino, Pacific Islander, and multiple race. As we continue to appoint candidates from the rapid recruitment events, we'll update our demographics data and share with you in future reports. When evaluating ways to move the needle towards a more diverse workforce and find ways that we, as a state agency, can measure, we use the CalHR annual workforce analysis to identify and measure the composition of our workforce against the labor pool in Sacramento. This includes several area counties, and we look at occupational group. These annual reviews help us gauge how we're performing compared to the rest of the local labor market. Next slide, please. So how did we do it? Equity was critical in this process. We adjusted processes to attract and establish the broadest candidate pool possible. Typically, multiple screening tools are applied in advance of interviews to reduce the pool from what appears to be a large pool to the most highly qualified candidates. Instead, for the rapid recruitment events, we used a minimum qualification review as a screening. This greatly increased the number of candidates we interviewed and also enabled us to discover highly qualified candidates that may have otherwise been screened out of the process. This decision quickly grew the applicant pool, and again, we ended up with over 600 team members or candidates that we interviewed. We used a central and automated repository with a tracking mechanism for all of our documents and reviews, so we were able to use a SharePoint system. This greatly increased the speed at which we were able to move to the next steps in the process, including scheduling and conducting interviews. Candidates and our new team members have told us it was surprising to get contacted so quickly after applying. After interviews were conducted, our highest scoring candidates were sent an initial offer for hire that we called our promise ring. Kind of a fun term, but that's what we wanted people to know, that we were very interested in them, so we didn't lose really strong candidates early on. We then began the matchmaking process to match candidates with jobs based on their job category interests, which aligned to program needs. Next slide, please. Inclusion gained from innovation was integral to the success of the rapid recruitment events. We used the established state rules, laws, policies, and procedures to maximum advantage to make hires across 6 different occupational groups. Hundreds of team members and leaders from across the entire enterprise came together and took on a broad range of team and individual roles. CalPERS is known for collaboration, and the rapid recruitment event was a true demonstration of our strength in that area. The candidates were direct beneficiaries of the organization coming together in such an impactful way. The very first team member that we appointed from the rapid recruitment events in HR sent a note that said, "This hiring and onboarding experience has been one of the smoothest and most efficient processes I have experienced, and it really put to rest all the rumors out there about how hard it is to get on with the state of California." Next slide. This is a simple visual with data from the HR Rapid Recruitment event to show how we converted a traditional selection funnel into a mechanism to efficiently establish a diverse candidate pool from which we hired qualified individuals, many of whom we hope will be future leaders of CalPERS. Well-scoring candidates who were not placed in an HR role became part of the generalist candidate pool for one of the enterprise rapid recruitment events, and several of them were placed in jobs following that portion of our rapid recruitment hires. Overall, it was a change for our hiring managers to use a process that was so different from traditional recruitment and selection. When they called references and spoke to the candidates themselves, most managers were very delighted, and at least in HR, where all of our team members have started, all 14 of our new team members are thriving in HR, and we're thrilled to have them. Next slide, please. A smooth transition from candidate to team member is key to establishing a trusted working relationship and lasting engagement. Our inclusionary practices extend across the employee life cycle, from pre-hire through the remainder of their career at CalPERS. We implemented a cohort-style onboarding to quickly acclimate our new hires. This cohort approach gives new team members an immediate group of known colleagues with shared experiences as they begin their career journey at CalPERS. Within the first 30 days, new team members are invited to participate in speed mentoring sessions. This exposes them to mentors and increases their business acumen and job knowledge. Our rapid recruitment hires demonstrate a positive shift in our onboarding feedback as well. The survey administered after the rapid recruitment event revealed that new, rehired, and newly promoted team members stated they felt more strongly that they understood how their performance was evaluated and that their onboarding process set them up for success. They were also more likely to recommend CalPERS as a great place to work. These positive trends help us measure success and know that we are on the right track. Next slide, please. I spoke earlier about one of our main goals being to expand our reach to candidates far and wide. We work with our colleagues in the Office of Public Affairs and the Office of Stakeholder Relations to get some incredible visuals and messaging for the rapid recruitment events. Hopefully some of you saw those on various social media channels. They branded the events in many ways and helped us maintain a consistent, professional look for all outreach channels. Next slide. We had many operational improvements in this project, as well as shifting the hiring and recruitment culture at CalPERS even further towards inclusion, diversity, and equity. We created a culture of trust through regular communication and quick feedback. We developed new ways to use available tools and learned, tested, and implemented them as they were proven. Project decisions used lean principles and practices, including using data to form decisions and predict outcomes and process timing. The project led to a vast knowledge transfer of HR and personnel concepts throughout the organization and allowed developmental opportunities for team members across the organization as well. Finally, it was a highly collaborative project with individuals from every area of the organization participating and volunteering to assist for the greater good of CalPERS and the state of California. Next slide. Remaining work for the rapid recruitment events includes reviewing and analyzing all of the initial data, requesting project participant feedback via surveys, conducting lessons learned sessions, implementing final process improvements to our recruitment and hiring process, and create a summary report to be presented at future meetings. We'll also track rapid recruitment event long-term success across standard HR metrics such as engagement, retention, performance, and development. So that concludes my slides, and so I'd like to pause here and see if there's any questions before I turn it back to Sabrina.
So I just want to, I don't really have a question, more of a statement. There is so much information here, right? But on the rapid recruitment, I just want to congratulate you. Having been a 29-year state employee, seeing this is like watching a miracle happen. So, congratulations. Excellent work. We're really proud of you guys for doing this work.
Thank you, President Taylor, and it was a huge team effort with so many people at CalPERS. So I say thank you, but it's all of them. So thank you very much.
Absolutely. Anybody else? Oh, I have Jose Luis.
First of all, I want to congratulate you on this rapid recruitment. I think it's fantastic because, as you know, we have a lot of vacancies, and this is such a cool process that has happened. I also want to congratulate you on the outreach process because I've seen some of the videos and some of the postings on social media, and it captures your attention. I mean, it's really cool. And then also, I also want to compliment you because as we all know, we also had that other video called Invest with Us or something like that, trying to recruit individuals in our investment office and so forth, and having such a difficulty doing that. So I really appreciate this. I do want to ask a question about process. And I saw the slide on page 28 on the entire mechanism of how you bring in the applications in, the interview, the candidate pool, the matchmaking. Now, the timeline on that, what's the average timeline? Is it a week, 2 weeks, 3 weeks? I mean, and just the flow and the workflow process. If you can just elaborate a little bit more on that, Michelle, that'd be awesome.
Happy to, and thank you very much for your positive comments. And I just want to acknowledge excellent partnership in Public Affairs who produced all of those beautiful videos and graphics. So we're very happy to have their partnership. So, so generally, I would say generally, and I don't have the exact figure in front of me, but generally it probably takes about 8 weeks if you're moving quickly to fill a position with the state. So you said 2 to 3 weeks, and I'm telling you 8 weeks would probably be on average how long it takes. So for this process, it was much quicker. So we advertised these positions. Our ad posted on, I believe it was Cesar Chavez Day, March 31st.
Okay.
We had our interviews the beginning of April, and our first candidate started on May 2nd. So that's just a little over a month, and we interviewed 600 people. So it was a lot. It was quite a bit of logistical planning. And so with that, so you'll see for this, we had candidates who received applications. We also had them complete an interest survey letting us know what area they were interested in working in and what their strengths were. Then we offered interviews to all the candidates who passed the minimum qualifications. We ended up interviewing 603, and then we did the matchmaking for 14. Now, obviously, this is a tremendous pool of people, and so we reached out to all of them. Communication throughout was really important. We wanted to make sure that we didn't, waste their time and that we took advantage of this tremendous pool. So we sent all of those candidates links to apply for the enterprise-wide rapid recruitment events, and we had a lot of communication around that. So many of them did apply and were successful in the enterprise recruitment events.
Incredible. And of the individuals that weren't successful, are they in some sort of pool bank in case we need to get them, if other opportunities arise and so forth? I'm just curious about that.
Yeah, so state advertisements are good for 180 days, which is 6 months. And so, yes, because the recruitment and the job controls for these were very broad, we will be able to use those pools for up to 180 days.
That's just fantastic. First of all, thank you. This is fantastic. Thank you very much.
Ms. Ortega, go ahead.
Thank you. Thank you very much. Thanks, Michelle. I just had a question on this slide in particular, and just to clarify the number of people who started here who turned into 14, and then how that connects back to the 109, and whether the pool got bigger than the 675 to get you to 109. I'm just curious about the drop off. That's why I'm asking.
Yeah, so for the HR one, you'll see that we had some people who submitted interest forms but no applications. So for the enterprise-wide rapid recruitment event, so we had 6 different occupational groups. Those were a generalist, which was staff services analyst, an associate governmental program analyst, investment officer, information technology, auditing, and accounting, and research. And so for all of those different 6 occupational groups, we had over 1,000, I think 1,200 and a little over 1,200 applications for all of those different groups. And so of that, many of them were including some of these 600 folks who applied to the HR vacancies. And so they didn't only just apply to the enterprise generalist ones. For example, some of them also qualified and applied for auditing positions or research positions as well.
So Michelle, let me ask, so these people were already qualified, having taken their tests to be in the AGPA or audit classification to apply for the job, is that correct?
Yeah, so candidates have to take an online test, as I know you know, for all of these positions. And so, yes, they would have taken an exam for either the auditing or the research, and then we would verify that they met the minimum qualifications for those.
Okay, okay. I was wondering about that first step. I forgot about that.
Yeah, it's all online now, so that makes it a lot easier. If we were doing exams, the way we used to, where it was all paper, we wouldn't have been able to do this.
Yeah, it's been a long time.
Yeah.
All right, thank you. I don't think I see any more questions, so if you want to finish up.
All right, well then, just to wrap things up, this is a view, going back to the EPM side of the house, of your Insight tool entry page. So each quarter you get an executive summary report that kind of highlights what are the items that are at risk or off target that might focus your attention on, and then the left side navigation takes you to each one of those goals and outcome measures. The link that's also included here is for the external website pages for our general public to access any of the reports as well. So with that, again, we'll be here to help assist anyone if you're interested one-on-one after we close out the session for today. Other than that, we're open to any other questions or comments.
Okay, so I have Melissa first and then David.
Okay, thank you so much for this great presentation. I always learn a lot, and I want to just go back to your goal of member experience and the strategic objectives and just make a comment. So I recently attended the CalPERS Benefits Education event in Bakersfield, and I just want to take a moment to recognize some of the team members, the CalPERS team members that made the event just phenomenal and educational at the same time, and I think it's somewhere in the strategic objective. So I want to stress first that it's some of the team members, and that is because it's my shortcoming that I didn't get their name or I didn't meet everybody. But I do want to give a huge thank you to Michael Trevino and the Fresno Regional Office team. I want to thank the presenters Kimberly and Andrea and the gentlemen of the Service Credit team.
Awesome.
I also just want to recognize that we had some CalPERS team members come out to Santa Clara County to work with our workers at O'Connor Hospital. And I want to recognize those team members that came out: Maria Marcos from the San Jose office, Luis Lemus from Sacramento, and Marcela Rodriguez from the Fresno office. They were so awesome, and I hope Santa Clara County hosted them. They had as much fun as the members had learning about their benefits and getting retirement counseling. Finally, I also want to thank Mr. David Rubio. So Dave was a superstar at both of these events, and he's just someone who's so accessible to our members and knowledgeable but for the member experience. It's so important. Definitely dedicated, right, a CalPERS career. And finally, there has yet been a CalPERS event that I attended where Kaylee her thoughtfulness hasn't saved me from myself. And she hasn't taken care of me in some way or another and done it with cheer and grace that I just only aspire to. So I want to thank her and just everyone else. My members aren't able to always come because they're at work, right? They're providing the vital services, the public services that keep our communities thriving. And so they're not here to say thank you. So I just want to convey on behalf of the members that I talk to and that reach out to me all the time to say thank you guys, thank you. Truly, CalPERS team members serve those who serve California. So thank you.
Thank you. I appreciate those accolades on behalf of this team. They're outstanding. Shout out to the regional offices. That's where I grew up for sure. And they are amazing people doing some amazing services one-on-one. So thank you so much for that.
All right. Thank you. David?
Yeah, thank you all. Usually when I'm looking at strategic plans and metrics and things like mentoring programs and recruiting programs, I'm asking people questions that I'm getting deer in the headlights. And I've been looking at this kind of stuff from the perspective of a Baldrige examiner, internal assessment auditors. Since I'm older than dirt, I started doing this stuff before I came here during the Duke-Majan administration. And so just huge shout out, thank you, and kudos to the whole team, from all the folks who worked on this, all the way through you all and up to Marcy, because I've seen so many of these kind of efforts that start with great excitement, whether in the public sector, in the private sector, sometimes with big long dollars and energetic executives pushing them, other times from the ground up a little bit, but they often falter. And years later, it was, been there, done that, or that was the flavor of the month, or that was our new commander, or our new director, or our new governor. And it was, and what this really reflects from this team and from Marcy and the executive is real constancy of purpose and a long-term sticking to it, because this isn't just these aren't just technical tasks that were accomplished. These all represent real cultural change that takes a lot of time and great leadership and great commitment. And having seen these things come and go and falter even in my own organization here in state government over the last 30 plus years, it's so inspiring to see this really done well, led well, and leading to good outcomes. And there's still a long way to go. It's a long road, but just so impressed, and really just want to share that appreciation.
Thank you so much. We appreciate those acknowledgments. Not everybody can appreciate performance indicator management, wearing the accountability hat, but exactly to your point is being consistent and staying committed and having that support from the top really makes a difference. And like I said, we've been doing this now for 7 years and it's not over. It's a constant evolution process, and it takes all the team to be involved to make it successful. So thank you for that.
All right. Thank you, Sabrina, Laura, Michelle. I have one public commenters. As Margaret Brown, if you could please come up for 3 minutes, and then we're done with the session.
Good afternoon. Is it on? Good afternoon. Margaret Brown, former CalPERS board member, and I'm also RPEA president for the Riverside chapter. Thank you for this report today. It's very informative. I'm just wondering, though, with the metrics you've mentioned a number of times that the board can find more detailed information on the Insight tool. I was part of the board when we created that tool, and it is very helpful. I would like to say that stakeholders and the media should have access to that same data as long as it is not confidential, and I do mean truly confidential. And with piggybacking on that, page 18, where you talk about the security measures, you know, one of the goals is stakeholder engagement and transparency, but a large number of these key performance indicators are secret or confidential. The member self-service fraud, unauthorized member self-service account changes. I've got to tell you, we want to know this stuff in the public. You need to tell us. Time to detect the security threats, that's a whole nother thing, but the big issue on the time is the time it took CalPERS to tell us about our data being out there on the dark web. That was not transparent at all for whatever reason, and so that really needs to be fixed. And this information should be provided to stakeholders if it's not truly confidential. I've always objected as a former board member to things being classified as confidential when they clearly were not. And then as an aside, some of us in the back were chatting among ourselves, and we were just wondering if the EPM team keeps count or track of the person hours required to track and report the EPMs. I think it would be really informative to know how many hours are spent completing this type of work. I know it's a broad range of people that you have doing this work, but it would be informative for us to know how long it takes. Thank you.
Doug Hoffner, CalPERS team member. Just respond to the first part of that question. The non-closed session confidential material is all available to the public. It's on our website as well. The Insight tool is just a reference to an internal vehicle by which the board could see the materials, but that is publicly available. It was posted back in May of the last quarter, and that will continue to be the case going forward.
All right, thank you, Doug. Ladies, thank you very much. Excellent job. We're running a little late, unfortunately. So our next session, we're going to take a 15-minute break, so we're at 3:36.
Power through, it's short.
You want to, is it short?
It's fairly short.
Well, let's take a few minutes and let people go get something to eat. All right, 10 minutes, guys. 46. 47, actually. Yes, it's for Gail. We're giving her 10 minutes to go get food. patient, and we are almost done. We're on the home stretch. Come on, David, get over here. Gail's gone too.
You're running people over.
Okay, our last session today gives us an opportunity to look at how we operate through the lens of transparency, which is so vital to the work we do and the members we serve. And presenting the information is Ms. Michelle Nix, Acting Chief Financial Officer, and you go right ahead.
Thank you, Teresa. You can hear me, right? I got the thumbs up back there. Yeah, I got the thumbs up. Okay, good afternoon, Michelle Nix, CalPERS team member. This presentation is actually a follow-up to a transparency presentation that we gave you in September. Some of you aren't on the board, so it may be new, but anyway, we brought that to you in conjunction with the CEM benchmarking group that we hire, and today's presentation will basically follow up on that and show you some of the stuff that we've been at and doing since we presented that. Okay, I'm running the thing. I've got it all figured out here. All right, so by the way, I was told to talk fast, so I can't promise that, sorry. CalPERS promotes transparency through outreach, online resources, and participating in cost-effective management, global pension transparency benchmarking. That's a lot of words. What that really means is that we have a lot of outreach efforts that we do to get our message out to all the members and all of our stakeholders. Some of the outreach events that we do are the CBs, and I think Melissa was talking about that just in our last presentation. The annual educational forum, employer training, stakeholder webinars, roundtable meetings, and participating in stakeholder events like this. We've got several online groups as well. We've got pages dedicated to stakeholder groups specifically, forms and publications, a dedicated page for investment and financial reports, and we post all of our board information online. In addition to that, our house records require us to put our webinars and our training and our board meetings on YouTube as well, so they're out there forever, so I always check to make sure I'm not wearing the same jacket twice. So last September, like I said, we presented the information about CEM, and we participate in 4 different surveys. Those surveys are pension administration, the cost, pension investments, global leaders, investment benchmarking, and transparency. The transparency one is new, and that's what we're going to talk about today. So let me switch the slide here. So let's see. We started the transparency, it's really new. They just started it about 3 years ago, the CEM did. And we've been participating in it ever since it started. And what happens is the CEM analysts spend about 4 hours reviewing our website, looking through our online documents and our basic information to see if they can find it easily. This is they're analysts, they might hire somebody, that isn't even familiar with pensions, so it's kind of a good test. They actually look for information related to cost. They look for information related to governance and organization, the performance, and responsible investing. So, the score is based upon 188 key metrics, and that's basically 188 questions related to 4 impact areas. They then take the score and they rank it against our peers, and it's global. So they just try to make sure that we're in the same equivalent size, although that's pretty hard for us. But they do this across the United States as well as the world. Last year, there were 75 funds that participated, representing 15 countries. So, last year, and some of this data is from last year because we didn't have the results, but the good news is we got them today for this year, so I'm going to reveal that here in a minute. But last year, CalPERS ranked first in the United States and fifth globally, a rank that was an improvement from the 11th the year before, so I guess it was 9th last year. During our FAC presentation last September, we received direction from the board to come back and talk about what we've done to try to improve our transparency scores. Now, although our scores, you can see on the slide there that although our scores, I lost my train of thought here, but although the scores were reduced a little bit from last year, you have to remember that CEM their scores are evolving each year. So they gave us an opportunity in 2001 to go back and edit our score, and then they actually did edit the score. Last year, they took a firm stance on no edits. So even though we went back and pointed out that, hey, here's our information, they didn't change the score. But now this year, they've got a formal dispute process. So they're evolving each year. The formal dispute process will allow us to point things out to them that they say we've missed or that we didn't have. So today, CEM actually released the information, which I'm happy to say that we were ranked #1 in the United States, and we moved up 5 spots from last year, and we're 4th this year. So that's kind of exciting. So how do we do it? It's still an ongoing effort. I might add that before I start this. But through our participation in CEM, we went through the report, line by line, and we decided what we could do quickly and what we could take on for later. And there is a lot of information, and CEM even acknowledged this in our report last year in their presentation as well, that we almost have too much information out there, and that it's confusing to stakeholders because it's hard to find. So we're trying to fix that. So some of the things that we did to fix that are we changed titles of information that had weird titles. It wouldn't be obvious to a person that was just looking or browsing our website. We also redesigned and renamed things. We put them in different spots to try to reorganize it to make it a little bit easier to find. And also, we developed what I'm going to show you here in a minute as our transparency report, which is an effort it's kind of a dual effort. So as you're aware that when I present in November the annual comprehensive financial report, it has over 200 pages in it. And I know you guys all read it, but everyone else probably outside of the board and a few really interested stakeholders don't read it cover to cover. And I know that's kind of disturbing to me since I spent a lot of time, creating this thing. So what we did was some other organizations actually create something called a Popular Annual Comprehensive Financial Report, which highlights things and makes it easier to read. So what we thought was, well, let's take some of the suggestions that CEM gave us and the Popular Annual Report and marry them together and come up with a thing that we're going to call the Transparency Report. And this is going to be a report that we can produce as we do our annual financial report that is, hopefully understandable and easy to use and easy to read for all stakeholders. So now I'm going to pull that up for you. I'm going to walk through it. Okay, so this transparency report is, I think, 10 pages maybe. So that's quite an improvement over the 200 plus pages of my ACPR. We start off with a letter from Marcy in the beginning of it, and then the first meaty page is the mission, vision, values, and strategic plan. Obviously, we put that in there because that's the reason we exist, is to fulfill our mission. So we want to make sure that's at the forefront of everything that we do. The next thing that we put in this report was facts that we felt would be really interesting to stakeholders. For instance, the pension buck that explains where our contributions come from, or where we fund the benefits from. The CEM cost, which last year was $223 per member. That was one of the suggestions that CEM gave us in our transparency report, was that we didn't highlight that. So we went ahead and highlighted that. Also, I thought that it would be interesting to put a few facts on there. So where we stand, for instance, our net position, our net weighted investment rate of return, our funded status, the number of retirees, is kind of all in a handy place for you to refer to. The next page is where our benefit recipients live. So you can see that the majority of, almost 80% of our benefit recipients are on the West Coast, most of them in California. So what this tells me is that this shows kind of the impact of what our retirees and our members, the impact financially that they have on California and the surrounding states. In fact, $53.7 billion is invested in California-based companies and projects as a result of our investments and our benefits, which is kind of interesting. I've taken the financial report and squished it down into this two pages, really. I tried to make it as rolled up as possible and still give the information, but this is basically the balance sheet of CalPERS on this page. We also include the budget and the net position and show you a trend of how that has changed over time. We also, you can't have a balance sheet without an income statement, so this is CalPERS income statement. And I also put in there some ups and downs. So it talks about, what did we do from this year to last year? It kind of compares it for you. So, for instance, we had an increased member contribution into the PERF of 402,664. So, it kind of lays it out for you in an easy-to-read format. Also, down at the bottom, we show the different contributions into the PERF fund, and that's by year. We have 2 pages dedicated to investments. Like I said before, we have investments in California, so that's there, and it's also broken out by asset class as well as what the percentage of the total fund of the investments into California are. So we, as CalPERS, then make a big impact into the economy. We also, I included the strategy to achieve net zero. You saw this yesterday in the presentation, but we'll keep updating this as that information, progresses and as the plan develops and they implement it going forward. This particular page shows strategic asset allocations and how we measure up to the, not the assumed rate of return, the graph at the bottom of the page shows what our actual return was, what the assumed rate of return was, and also on the same page it shows the strategic asset allocation and how the actuals measure up to the approved strategic allocation that was given to us by the board. We are all about sustainability and transparency, and so this was an important thing to include in our report. CalPERS is known as a universal owner of investments, which means we own a little bit of everything across all of the global financial markets. So in this particular slide or this page on this report, we wanted to highlight our efforts for engagement with other companies. So it shows here at the bottom of the page that we have cast over 8,500 proxy votes in 2022 worldwide. The next page is the membership page. The infograph in the middle of the page shows a breakdown of how we divide our members among the different types of employers. So you can see in the actual ACFR, we have 3 columns, perf A, B, and C. It's all one big perf, really. But what we divide it by, what that means is we divide it by type of employer. So here you can see all the different facts from the different types of employers. We also included a table at the bottom of the page for the average benefits by years of service at retirement. Moving on to the actuarial page, we have some trend data there that shows you the funded status over 10 years. That's always important to see. And then also, we have member statistics on here. So you can see that the average annual monthly benefit is $3,420 per member. And that's the average. And they have 20.5 average years of service. Highlighted a few of our awards. This is probably not a comprehensive list, so as they get pointed out, we'll probably add more to it as we go along. We wanted to include a page on diversity and equity and inclusion. That's obviously one of our important goals and strategies, so we put that out there, and we will continue to put that out there as we go along, and if anything changes, we will add to it as this report grows. Well, it won't grow, hopefully, page-wise, but as the information becomes more current. I'm trying to keep it as short as possible so that it's usable. All right, so this next page is workplace demographics. Thought this was interesting. This information is what we've collected within the CalPERS workplace. So it kind of highlights and goes along with our DEI efforts. So the next page is more facts about our membership and our customer service. As I mentioned earlier, our mission is obviously to deliver the retirement and health benefits to our members and beneficiaries. So this particular page shows information on how we've delivered that information. We took over 1 million calls last year, and we had 4.6 million website visits. So our customer service groups are really busy, and they're happy to do it, of course. So the next page is transparency regarding the training and education and outreach. And so there's some statistics on this page about how many CBs we've held, how many participants were there, what we've done to try to educate and make our members more aware of what we do at CalPERS. We also have included information on the Pathways Conference there and the stakeholder outreach team. So that's just an event that I think is probably going to, based on the success that we had last year and the year before, I think that event will probably continue forward because it really touched a lot of people's lives. And I also included your lovely faces in there, the board members, because obviously that's the people that are responsible for the oversight of our pension funds. So I thought that was important to include. So what to expect next? That's the end of the report. That's the back page of it. It prints flat if you feel so inclined to print it, but we will put it on the website, and I think there's one in the back of the room if you want to actually take a peek at it. So with that, we're going to go back to the slide presentation that I had, and we'll continue on here. All right, so what slide are we on here? We've done all that. So what to expect? So at the time that we wrote this presentation, we didn't have the information that we're, again, #1 in the US, and we moved up 5 spots to the 4th globally, but we know that now. So maybe I'll say it again in September just to prove this slide right. And we plan to go ahead and design and publish and make this transparency report available to all of you. One of the things that I had in my mind when we started this project was a tool that you could use to take to your stakeholders, your constituents, that would have interesting facts and things that you could refer to as you talked about CalPERS. So hopefully I achieved that, and of course it wasn't all me, but it's a collaboration, sorry. It's a collaboration with public affairs and many other divisions throughout CalPERS to make this actual report happen. But we plan on making it happen every year in conjunction with the annual report, the financial report. And that concludes my presentation, and I'd be happy to take questions.
Good job. Oh, Jose Luis, of course.
First, sorry, Kevin was. Anyway, first of all, Michelle, thank you very much. Yes, this transparency report is fantastic. In the past, I've used the pension at a glance, finance and is it
Facts at a glance, I believe.
Facts at a glance, and other resources to kind of put together information. And this is so cool that it's been all in one report that is just easy to find. All the things that we talked about, our DEI, our strategic plan, our finances, our investments, in one comprehensive viewpoint. I think it's going to be very useful, especially when I go and speak with the stakeholders.
Mm-hmm.
It is going to be like an additional handout, additional information on what is going on with here at CalPERS, our CalPERS story. So I really appreciate it, and thank you for the entire team. I know this was a enterprise effort, and I just want to say thank you very much.
Thank you for the feedback.
You're welcome.
Michelle, great job, by the way.
Thanks.
Yeah. Go ahead, Kevin. I'm just in shock that you're talking today.
Thank you, President Taylor. And on that note, I don't want to steal your thunder, but I do want to share my congratulations being moving from the top 10 to the top 5 globally. I know that is a huge undertaking, and I just want to share my congratulations to you and the entire team for the work that you're doing in this transparency. So thank you.
Thank you. It's a moving target because while we try to make ourselves better and go line by line, everybody else is doing that too. So, it's always kind of a hold your breath moment because all the improvements we made, we just hope that the next pension fund didn't make, 2 more or whatever, however many more that it takes to stay, in that rank, so.
Well, it's the little stuff. Last year it was something really little, right, that put us down at 9th. I think.
Well, I think there was so much information, and some of it was labeled funny, and it was just not as easy to read as it should have been. So we corrected that.
It's all there. Yeah. All right. I want to thank everybody. Oh, Frank, I missed you. I'm looking around. Oh, you had your hand on it. That's why I didn't see it. Okay.
That's okay. Thank you, Madam President. And real quick, ditto the congratulations, Ms. Nix. We're looking forward to see it, and yes, we're going to read it and cherish it, maybe even frame the first edition. Speaking of, and I may have missed it, but when can we expect to see the first inaugural report?
Well, it's ready, actually. We just finished it last week, but it's ready to go, so we'll have it up on the website as soon as we get done with this week and get back. And I have to probably ask the public, whoever posted, I think it's Brad's team, when they can do that. I can't speak for them, but we'll get it up there as soon as possible.
Wow, that's great. Thank you.
And most of this data is from last June and the last ACFR because the new one hasn't happened yet. We're in the process of closing the books this month, doing the audit, and as soon as we can get all of that done and churn through and that presented to you, we'll have this ready as well.
Yeah, J.J. Jelenzik. I actually had a
question, and then I think you may have answered it in response to Frank. On slide 6, it says the June 30th, 22 transparency report. And so I said, well, that's a long time. So I went looking for it and couldn't find it anywhere. But if I understood your answer to Frank, you haven't published it yet.
Yeah, we finished it last week.
Okay. You may want to think about whether you want to call it 22 or not. And the other point I would make is if you really want to improve the transparency, make the blankety blank search function on the website much better. Thank you.
Sorry. I do want to remind our board members that staff is still here to help you with insight if you want to find out where all of this great information is. And other than that, we are adjourning the session for now, and I appreciate everybody. I think we're supposed to be back here at 9 o'clock tomorrow. Thank you.